Welcome everyone to C3 2020 Virtual Coronary CTO session. I'd like to welcome Pakistan Society of Interventional Cardiology group, Dr. Bashir Hanif and several of his colleagues, also Five Continent Congress and Great Wall Congress, along with Anzan Hospital in Beijing, China, and also the Asia Pacific CTO Club. So I know it's a wide time zones that we are transmitting this to today. We're thousands of viewers. So without ado, I'm gonna get this session started. So it's my privilege to invite Dr. Jaikirshan Khatri, who is an interventional cardiologist at Cleveland Clinic and also a contributor of C3 Congress. He is going to discuss why do we treat coronary CTO in 2020 and what's the new evidence and current literature. Jaikirshan, it's all yours.
Great, thank you so much for the invitation to speak today. Let me pull up my slides. Okay. So this is a task that I don't know that I'm necessarily qualified to speak on, but what I'm going to do is just share some of the historical data and some of the current data that I use to inform my clinical practice in CTO PCI. And hopefully this will help to convince the audience in terms of why we should do these types of procedures. So we all know from this historical information that the myocardium that's supplied by CTO is ischemic. The collaterals that are there are not sufficient to provide the blood supply to avoid ischemia and symptoms. And this is shown in this rather elegant study done by Dr. Werner back in 2006 that all CTOs have FFRs that are less than 0.8. And this seems to be independent of the size and the quality of the collaterals that are available. It doesn't matter how big the collaterals are. This myocardium that's subtended by the CTO is ischemic. And we already know from other trials like FAME how important FFR is in terms of deciding when to treat a vessel that's still open. So I think that the same sort of data could be applied towards when to treat a CTO. They're all ischemic, and it's just a matter of figuring out when it's appropriate to do something about the CTO. Looking at large unselected patient populations, we know that having a CTO is associated with mortality, particularly in acute coronary syndrome. So this is a study looking at patients presenting with STEMI who had a concomitant CTO in a non-infarct vessel. And you can see in the red line the dramatic rise in risk of mortality at 30 days. And this does not subside over time. You can see out to 36 months, the curves continue to separate with a much higher hazard of death in patients who have a concomitant CTO as their non-infarct vessel. How about all comers? So this is data from the SCAR registry. So all patients in Scandinavia who have coronary angiography for whatever reason are in this registry. And you can see that the presence of CTO at the time of angiography is associated with cumulative mortality, and that treating the CTO, if successful, can actually reduce the risk of mortality. Now, in SCAR registry, the overall attempt rates are pretty modest at 8%, and success rates are also modest at 54%. But you can see this interesting trend that treating CTO successfully can achieve a reduced risk in mortality. And this association seemed to be the strongest amongst younger patients who presented with acute coronary syndrome. What about softer endpoints? So this is data taken from the Open CTO registry, which I think is probably in the current era the most reliable data. This is 1,000 patients of prospective registry done in the United States. All of the outcomes were adjudicated, including the core lab. And what they show is that there's a dramatic improvement in 30-day health status in patients who undergo CTO PCI. That's in the Seattle Angina Questionnaire, as well as their overall ischemic burden. Their overall quality of life improves after PCI. Looking at a little bit more objectively, what do we achieve by treating a CTO? And one of the things that obviously we'd want to do is improve LV systolic function. And how can you measure that objectively? And this is older data that I want to share with you. looking at MRI findings in patients who present with CTO. And you can see that in patients who have less than 25% scar, there's a dramatic improvement in the segmental wall thickening demonstrated in these patients after CTO PCI. This is an improvement that's seen 5 months after intervention, and it's sustained up to 3 years of follow-up. Whereas in patients who have a thicker level of scar, that benefit's not seen. So this gets to the whole idea of how to select out the right patient. Patients who have viability are more likely to enjoy clinical benefit. And this has been shown in a lot more contemporary trials as well. So this is a much more recent paper looking at a small group of patients, 50 patients with CTO presented to the center, and they all had MRI done, looking for both ischemia as well as viability. And of the 50 patients, at least 32 patients met the criteria by MRI for ischemia and viability. And what they showed after successful CTO intervention is that the perfusion defect resolved in over 90% of these patients by MRI. And the ejection fraction also improved statistically, and the quality of life by Seattle Angiogram Questionnaire also improved in these patients. So a more contemporary analysis using MRI to select patient population for CTO intervention. This is looking at this in a slightly different way. This is looking at MRI for viability and PET scanning for ischemia. Same idea, pre-procedural analysis to look for ischemia and viability by 2 different modalities. And the investigators saw basically the same thing, that in patients who had a successful CTO intervention, that there was a dramatic improvement in myocardial blood flow. And there was also an improvement in wall thickening by MRI after successful CTO intervention, resulting in an improvement in LV ejection fraction. So other more objective ways of looking for clinical benefit in CTO intervention. What about randomized clinical trial data? This is what everybody's most interested in. So this is one of the earliest randomized clinical trials that was published, the EXPLORE trial. And this is a small cohort of patients, 304 patients enrolled over a long period of time, over 8 years. Patients who presented with STEMI who had a concomitant CTO on presentation. The overall success rate of CTO intervention was low by current standards at 73%. And what's most important is there's really no assessment of baseline viability or ischemia in this trial. But what they showed is that there was no significant improvement in LV systolic function or dimensions after CTO PCI as measured by MRI. There was a trend towards improvement in patients who had an LAD CTO, but in the overall patient cohort, no significant improvement was seen. But the raises the question of, is overall LVEF really a sensitive enough measure in these patients? And this is a sub-analysis of the EXPLORE trial data, looking at segmental wall thickening rather than overall ejection fraction. And what they show with this sub-analysis is that in patients who had CTO PCI, if you look at the global function, there isn't much of a difference. But if you look at segmental wall thickening in only the dysfunctional segments, you can see a dramatic improvement in wall thickening in areas that had baseline dysfunctional motion by MRI. So, you know, perhaps using EF by MRI is not sensitive enough to measure, and we need to be a little bit more specific in what we're looking at to understand the clinical benefit. This is another trial that was done not too long ago called the REVASC Trial. It's a single center randomized clinical trial of 205 patients that were randomized to patent vessel PCI medical therapy versus CTO PCI. And the primary endpoint was segmental wall thickening by MRI. And what they reported was no real significant difference between the 2 cohorts. What's interesting here is that 60% of the control group underwent patent vessel PCI versus only 16% of the CTO PCI group. So one could argue which one of these 2 groups really got complete revascularization versus which group was left incomplete. The baseline ejection fraction in both of these groups was high. The baseline EF in both groups was over 50%, which could make it kind of difficult to demonstrate any incremental gain. And the biggest issue, I think, with this trial is that, again, CTO PCI in this case was not really guided by ischemia and or viability. Basically, patients were referred and enrolled in the trial without pre-procedural assessment. The EURO-CTO trial is a trial that was published back in 2018. It's a randomized clinical trial of 407 patients throughout Europe who have CTO and angina. So now we're talking about patients who have CTO and symptoms that were randomized 2-to-1 to PCI versus medical therapy with 12 months follow-up. This cohort had a very high success rate, 86%, which is comparable to other contemporary registry data, with a significant improvement in the Seattle Angina Questionnaire score compared with medical therapy, with similar MACE rates, and improvement in angina burden by the Canadian Cardiovascular Society Angina score. And there was a reasonable amount of crossover, at least 7.3% crossover into the PCI arm due to ongoing angina. And this gets at one of the other points that makes doing a really good randomized clinical trial difficult. The genie is effectively out of the bottle. We have enough experienced operators and enough referring doctors who believe in the benefit of this therapy that it's very, very hard to do a solid trial where we can cleanly avoid crossover. And that gets to the trial that probably made the most press, and that's the DECISION-CTO trial, which really showed no difference in MACE in patients who undergo CTO PCI versus medical therapy. This is a very large trial, 834 patients in 19 institutions throughout Asia, in patients who present with silent ischemia, stable angina, or acute coronary syndrome that were followed for over 5 years. They had a very high 91% procedural success rate. The primary endpoint that the study investigators looked at was a composite of all-cause death, MI, stroke, and repeat revascularization in the intention to treat population. And they really didn't show much in the way of a difference. The biggest challenge here is that it wasn't really medical therapy versus CTO intervention, because in the medical therapy arm, all the patent vessels were treated. So it was really multi-vessel PCI and medical therapy versus CTO PCI. So again, not exactly a comparison of medical therapy versus CTO intervention, which makes it hard to really understand what to make of this trial. To put it all into perspective, if you're a believer in the benefits of CTO intervention, how risky is it? Is it worth it to do it to a patient? So this is, again, the open CTO patient population analyzed through 2 different risk scores, the NCDR risk score and the Society of Thoracic Surgery risk score. So the patients that were in open CTO by these 2 risk scores had anywhere between 0.4 to 1.7% risk of mortality, whereas the actual observed mortality was 0.9% in open CTO. And to put that into comparison, a procedure that's done every day without debate is vein graft intervention. The vein graft intervention in NCDR carries a 1.1% risk of mortality. So we're not really talking about doing a procedure that is dramatically different than other procedures that are well accepted in the community and are done regularly without debate. So putting that all together, you know, the data is somewhat limited at this point, and I don't know that we're ever going to get that really clean randomized clinical trial, because there's just too many people, referring doctors and proceduralists who believe in this now, and it's very hard to go backwards because of the people that have benefited from it. This is an algorithm that I like to use. I tier my patients based on symptomatology, which would be the #1 type of patient, CTO patient who has symptoms that are refractory to medical therapy. That's who I would treat without really much debate. The second tier of patient would be patients who have ischemic burden, whereas they have ejection fractions that are low and heart failure, or they have ventricular arrhythmias that need to be treated and they have a CTO. That would be the second and third tier patients. Patients who have CTOs with good EF and no symptoms are people that we, at this point, really don't favor PCI for and advise medical therapy. And then obviously there are a subset of patients who are young, who have concomitant multivessel disease, who may benefit in the long term from bypass surgery. So I think that we still include that in our algorithm. So in conclusion, I would say that advanced CTO PCI techniques are very effective and have an acceptably low complication rate in high volume experienced centers. And we need to focus our efforts on selecting the patients who are the most likely to benefit clinically. And I think the #1 thing to focus on is symptom relief. That's really where the current evidence is guiding us. A lower level treatment would be patients suffering from ischemia with ventricular arrhythmias, low EF, and goal of trying to reduce that burden. But most of the data is observational. CTO PCI therapy requires really sound clinical judgment and in a multidisciplinary approach to provide the best care for the patient. That's hopefully on time, Raj?
Yes, perfect. Thank you very much. Any comments from the panel members? You know, we continue to have debate about whether to treat CTOs or not to treat CTOs, some conflicting data. A very nice summary by Dr. Khatri. Any comments?
Yeah, so Raj, you know, I think I had a quick comment, if you will. So I think Jed did an amazing job of synthesizing the data, but I think it reconciles with even data in the non-CTO world in the way we handle CAD in 2020. I mean, symptoms win, whether you look at ischemia in a CTO subset, whether you look at the ischemia trial itself. So I think in a patient who has symptoms, I don't think there should be any doubt, symptoms that are refractory to good medical therapy. The challenge becomes, as Jeb pointed out, the asymptomatic patient or the patient with concomitant multivessel disease with ischemia on a nuclear scan with a CTO. And I think those patients, my belief in optioning medical therapy first has become stronger based on the data from ischemia. So I won't jump to fix those, where probably a few years ago, I was you know, a big believer in ischemia reduction based on some of the meta-analysis and the data that had been presented earlier. And I'd open it up for the other guys on the panel, but that's sort of my
that sounds good. Let me ask a couple questions that has come from Pakistan, Dr. Chaudhry.
I was saying that this, what Ashish mentioned, and I think in our part of the world, this really becomes more relevant because when you do a CTO PCI, cost is significantly more than even the routine PCI. And I think we really need to select patients and make sure that patients fail medical therapy for their symptoms before we move on to the CTO PCI.
What about this is the question that has come from the audience, is that if the symptoms are controlled, but the ischemia test shows significant ischemia, what to do about a patient like that?
So let me jump in. I think and to that point, as well as trying the other comments. So first point to make, the majority of these patients, whether in open CT or the other trials, they don't have classic chest pain. A lot of times they have angina equivalent symptoms. They are tired, they're fatigued. They might feel, oh, I'm getting old, I'm getting fat. And then when they have to adjust the lifestyle, a lot of these patients, instead of walking 2 miles a day or 3 miles a day, they are giving up. Oh, no, I'm fine. Or why are you fine? Because I don't exert. I sit down, I take my time. In doing this, I think all panelists would agree, been doing, doing it for such a long time. These patients appreciate dramatic change in the lifestyle so many times. Sometimes these patients come back crying that this has changed my life. And I'm sure that that's the experience of all the panelists, which we have discussed before.
There is one more question, and then we will continue on. Do you recommend CTO PCI to improve left ventricular ejection fraction as a primary indication?
This is very controversial. This is Cal here. So there are now several trials that shows the segment improvement and what we shot for in a clinical trial. Some trial by Mishiaki trial did not actually show improvement. However, there was not much low EF in the trial at the start. So those patients, unfortunately, were excluded from the ischemia trial. So at this stage, I'm still revascularizing patient with ejection fraction less than 35% or less than 40 if medical therapy did not actually improve their ejection fraction and they're still symptomatic. Now, the asymptomatic patients, you have to be careful how asymptomatic they are. As Parag said, those asymptomatic patients, well, I'm 70 years old now and I'm not supposed to do what I needed to do. And you really have to ask the patient very probing questions about these things. He said, like, what did you do 5 years ago and would you like to go back and doing it? And if you talk to most of those patients, they are actually symptomatic. So we still, in our institution, we still cannot do it for improvement in ejection fraction. However, we get most of our patients referred to us and they've been on long-time medical therapy before they came to us, but there are something bother them enough to kind of travel to come and see us.
Okay. All the faculty, I encourage you to look in the Q&A section, which is at the bottom of your screen, because there is a ton of questions from the attendees. I think we have a very large number of attendees today. But in the interest of the time, I'm going to have to continue with the session. It's now a privilege to invite Dr. Craig Thompson, who is the director of cardiac catheterization laboratories at NYU Langone Health, and he's also a professor of medicine at NYU, and a well-known interventionalist who performs the CTO. He's now going to discuss how to evaluate CTO angiogram to achieve the best success. Craig, welcome.
Thank you very much. Raj, you just want to do a quick check here. Can you see my screen and hear me okay?
Yep, looks great. Yeah.
Wonderful. Thank you so much. I mean, first, thanks everybody for attending on a Saturday, and certainly Raj and the course directors for inviting me and the faculty along. It's going to be an amazing morning. So I'm charged with having what will be a brief discussion about optimal angiography for CTOs. And one has to start a procedure the correct way in order to have good and successful outcomes. And in CTO, there's the hard way and the easy way. And in some of the life experiences, I think, of CTO operators, and there is data to support this, but simply optimizing your angiograms, not doing ad hoc CTOs except under more specialized circumstances, but certainly having that be the exception to the rule, being able to study a proper angiogram going into the procedure, realize that when we're doing CTO PCI, we're playing chess. When we're doing routine coronary intervention, we're playing checkers. It's two different games, and simply having two catheters in, staging the procedures and studying probably increases success rates by 15% and drops safety rates, cuts major adverse complications in half. Literally the easiest thing you can do. Don't do it ad hoc. Study the angiograms, get proper angiograms, and you're likely going to have your patient will likely have a better outcome. So when we review angiograms, I think one has, whether you're a CTO operator just doing diagnostic studies or all of the above, is you take a diagnostic angiogram with an end goal of how am I going to have this patient revascularized in mind. Now, granted, in some circumstances, it may be surgical, in which case you need to have a good understanding of your targets and so forth. But if it ends up being a percutaneous solution, which is our subject material for this morning, you have to be able to have the information in order to study and plan your approach. This is one method, the hybrid algorithm, that many of you know. There are others, but I think fundamentally, irrespective of what anyone's dogma and strategic interventional approaches are, is the questions that you have to ask of yourself before one embarks on percutaneous coronary intervention for total occlusions is fundamentally the same. This is a strategy that asks effectively 4 fundamental questions from an angiogram and drives us to a sequence of approaches that tend to play off each other, both for safety and success, and is teachable and reproducible. And the 4 questions are effectively this, and I borrowed this angiogram from Dr. Pershad, so thanks very much, who's on our panel. But the 4 questions are this, is what's our understanding of the proximal cap? Can we safely put a sharp wire, a stiff wire, and a 2 to 3 French catheter or balloon into a space that we can't visualize? Do we feel comfortable with that, or is there ambiguity? Is there uncertainty that we're incapable of unraveling with angiography or maybe adjunctive IVUS or other imaging tools? So what's going on with the proximal cap? What's the lesion length? Lesion length is a long time, well-studied, well-defined surrogate for being able to successfully wire a lesion or wire a lesion both successfully, safely, and in a certain period of time. And longer lesions are amenable to CTO PCI. However, it changes the strategy. It makes, it raises the likelihood that one's going to need to use more advanced techniques like an antegrade reentry method or devices, or the retrograde approach. So if it's a long lesion, one needs to understand, okay, what are going to be the trade-offs that I have to think about if I'm going to have to be using more advanced measures to cross this lesion successfully. The collateral patterns in their anatomy, and in general, if you're going to perform an interventional procedure, you're asking yourself about interventional collaterals, meaning that there's a collateral that within a reasonable modicum within your particular experience in your hands that is safe and effective to cross if you would need retrograde approach as a primary or secondary strategy. But the other aspect of collaterals isn't just the interventional collaterals, it's where are they coming from and where are they landing? Because even if you're coming in the antegrade direction, and if you're in a situation where you share collaterals or you lose collaterals, the patient could still get quite ischemic from this, and you could lose perfusion to the target artery. So understanding where these are and what the effectively in your mind, thinking about what the risk ratio is of interfering with these will be incredibly important. And then the health of the distal target. The distal target, whether it's wiring, whether it is a reentry device, if you have a good landing zone, it oftentimes favors antegrade approach. If it's a poor landing zone and you can get in from the retrograde method, then you actually have control of this distal bed. And it also, again, going back to the algorithm that I previously had on the slide, informs our decisions. And the other is for PCI, catheters and collateral sources. So if you look at this angiogram, it's obviously a proximal right coronary CTO, big nest of bridging collaterals. If you were to start in the antegrade direction, and we could argue whether that would be a good approach in this case or not because of some ambiguity at the proximal cap, but let's say that you do. We're going antegrade. Is the moment that you start interfering with this lesion, those collaterals may regress, and your collaterals from your donor arteries might enhance. So you'll find that during the course of these cases, one would be tempted here to say, oh, I'm just going to put in a single catheter, and we'll try to get a wire across and so forth. The moment you start with this lesion, you're going to lose visualization, particularly of this critical segment of the distal landing zone, to assure that your wires and devices are in a safe place and you're not going to be less likely to encounter complications and so forth. So this multiple catheter sourcing on the interventional side is incredibly important. Now, when it comes particularly on the diagnostic side, which I think is important, I think those of us on the panel and others in the audience that review angiograms on a daily basis when it comes to total occlusions realize that you have angiograms at times that are very helpful for preparing for a subsequent complex procedure, and some that are not. And typically the mistake mode, the failure mode of the diagnostic modality in terms of informing us, properly informing us is multifold. I think oftentimes we will see high magnification because there's kind of a typical interest of interventional cardiologists to mag up and see a vessel up close and personal and then do a lot of panning. The problem with the total occlusions is between collateral bed filling, late filling of the distal total occlusion is one cannot get the entire picture. You may miss, if you're focused in one area and panning, is you may miss that particular sequence that you would need to be able to do a frame-by-frame analysis to plan a procedure. So low magnification, you see a CTO, back off to a low magnification. You're not panning, you'll be able to see everything in one field of view when it becomes time for you to truly study the angiogram offline to prepare for the interventional procedure. You need to opacify the collaterals. Oftentimes, you can't really make your final judgment until you have dual catheters in, which is typically at the time of intervention. I will say that there's a little trick of mine that I tend to do mostly radial, but if I happen to be femoral, occasionally during a diagnostic, I'll upsize to an 8 French, put 2 4 French catheters in the coronaries. There'll be a little bit of bleeding through the sheath, but you can actually get a dual angiogram and then take that offline to be able to study it. But usually your final analysis is when you're going to have catheters in all areas that are going to fill antegrade, retrograde, or otherwise fill the collateral bed. And one needs to stay on the angiograms a little bit late in order to truly see and try to get a better sense of what the CTO length is, what is the health of the distal target, where am I going? So the angles when one's viewing the collaterals can be incredibly important. It may be a little bit too nuanced for this discussion, but there are very frequent collateral patterns that one sees in CTOs, and less frequent ones that are become nearly reportable. But you know, if the right coronary is occluded, you're looking for septals and epicardials. You know, if something is occluded in the lateral wall, your nearest neighbor tends to donate the epicardials. So diag feeds a ramus, ramus feeds an OM, OM feeds a right coronary posterior lateral. There's AV groove collaterals going in both directions, typically from the right coronary to the circumflex system. So CTOs tend to occur in clusters in certain locations in a coronary artery, and the collateral patterns going in a variety of directions tend to follow a pattern as well. There are certain angles that can expose those, allow you to better plan a follow-up procedure and understand the anatomy, and modifying the angles during the diagnostic procedure will inform the interventional procedure. Don't pan. It makes, when you really have to study these the angiograms frame by frame, is if the camera is moving, either the collateral you're catching at the wrong point during the procedure, or you lose resolution to be able to see what might be a beautiful inline collateral that'll either help you with imaging, if not be an opportunity for a retrograde approach. So no panning during your setup shots. And then the offline and detailed review of the angiograms, and really all angiograms that have occurred along the way. You may have historical angiograms when the vessel is open, and that's incredibly important and informative for follow-up procedures if the vessel has become closed or has had previous PCI stenting and so forth. So all the information at your disposal. The opportunity with staging is to truly come in with information. So in this circumstance, if we're doing angiographic analysis, we have two catheters in. Now we have a better understanding of what the proximal cap looks like, what the lesion length is, potential collaterals, the health of the landing zone. This informs how we do follow-up procedures. So again, proximal cap, is it ambiguous? Is it tapered? What's the location? Can we find it? And this may inform opinions. Do we do IVUS to understand the proximal cap, or do we do an alternative approach such as bypassing the proximal cap antegrade or using retrograde techniques? The CTO segment itself, and typically if one can define what the course is, it's very useful. There are countermeasures you can do during a procedure to reduce the ambiguity, such as knuckling techniques and other techniques that keep you within the vessel architecture. But primarily you're looking at the lesion length. This is going to be really informative of the initial approach. The distal cap itself, can we see it? Do we understand it clearly? And really, what's the health of the landing zone if I need to use a reentry device? If I'm trying to wire it primarily, am I going to have difficulty? This will influence my device strategy, wire selection, and so forth. And then the collateral vessels, as we had mentioned a moment ago, what is the grade? Is the patient really dependent on primarily a single collateral source, which might increase risk if it's used as retrograde technique? Is it epicardial? Is it septal? It allows for one to be able to make risk-benefit trade-offs in terms of the subsequent interventional procedure to come. So and that's really the fundamental issues with the collaterals. And then there are favorable and unfavorable collaterals. Typically, the big categories is if you're getting retrograde, going through a bypass graft usually is, with the exception of maybe a lima, is usually a way to get retrograde relatively safely. Septals tend to be lower risk than epicardials. And epicardials, as well as all other collaterals, your ability to get across and the likelihood that you're going to assume additional risk during the procedure typically has to do with the size of the collateral and what the pitch is, meaning the sharpness of the angles and how close they are together. Long, loose angles in a large collateral typically is more easily negotiated than is a high-pitched, sharp collateral where you have to make many turns and is more likely to either get kinked or perforated and cause adverse events or create a little bit of a fire drill and difficulty during the procedure itself. So this, for instance, this is just simply, it's a left main trifurcation. This looks like it's intact when you have two catheters in. It turns out it's a bridging collateral, and this is 3 separate CTOs that we did under protection not that long ago. But the dual injection and understanding every landing zone, every opportunity for retrograde, where our antegrade opportunities are, and how to avoid these bridging collaterals, because we went in both directions. I think two of the 3 vessels we did antegrade, one was retrograde or something to that effect, but it informed safely the sequence of how we did it, and the technical approaches and the follow-up approaches when some of those go into failure mode. And that's just a final angiogram and the details of the procedure are otherwise immaterial. So to conclude, I would say that these detailed angiograms during diagnostic and interventional procedures are really a key for evaluation, strategy, safety, and success. They're the 4 basic questions we need to know, irrespective of the techniques and devices you have in your hands at your disposal. You need to understand where the proximal cap is, or if it's not obvious to you, it informs the approach. How long is the lesion? What's the health of the distal target? And what is the situation with the collateral circulation? Low magnification, no panning, good use of angles, and typically, more often than not, multiple catheters, at least when you get to the interventional portion of the procedure. So with that, Raj, I will stop, and I think we can answer questions and or move on.
Thank you very much, Greg, for that wonderful overview. I learned a lot on how to interpret CTO angiography by keeping an eye on radiation protection, as well as all the important aspects of CTO lesions. So I'll open up for any comments from other great faculty that's here with us from all the different continents. I also want to invite Dr. Jjyan Chen, who has joined us from China, who is one of the professors and a great CTO operators in mainland, and has made a special accommodation to be with us this evening. Welcome, Dr. Chen.
Yes, well, thank you very much, Greg, for your excellent lecture regarding how to make a very good coronary angiogram before the CT intervention. And Greg have also discussed every detail about how to make a good quality of picture and how to analyze it. And I think it's very, very important for the success of CT intervention. For the success of CT intervention, it's just based on a very good planning and very good judgment, and also its technique. And being a good coronary angiogram is very good fundamental for the success of CT intervention. Thank you very much, Greg, for your excellent lecture.
Thank you very much. I also like to invite Dr. Eugene Zhao from Anzhen Hospital. He's president of the cardiovascular division at the Anzhen Hospital and director of the 5 Continent Congress. And he's also, I know it's late in China, but he has joined us. Thank you very much for being with us.
Professor Davey, the Chairman Davey. So I just a question about the excellent speech about in the China, our center, most so CTO kits for select dual transradial approach for the moderator complex CTO, and other about use Goran approach and 7 or 8 French guiding catheter, and another select the 6 French guiding catheter transradial approach, another approach. But what do you think the large guiding catheter, like the 8 French, 7 French guiding catheter, maybe increase success rate of CTO? Or what do you think this approach maybe have influenced the success rate?
Yeah, I've got to say, I guess my response to that is typically my favorite starting position for most patients with CTO is 7 French biradial. I think that keeps most of your options available, gives you excellent support under most circumstances. It's pretty rare that I would use 8 French anymore. The only one circumstance is if one is having to do concurrent IVUS with a microcatheter with some systems. But in general, I think 7 is a really good trade-off between strength, but keeping a small size to reduce complications. And there are a few exceptions, obviously, with prohibitive angles and vascular disease. I think proximal right coronaries can be very difficult from a radial because of the respiraphasic variation. When they breathe, you lose support. But other than that, I think I enjoy 7 French biradial, so I try to set my procedures there personally. I'd be interested. I see Cal Alaswad's with us, and I know Cal's a huge radial enthusiast and may have comments.
Yeah, Dr. Zhao, in my practice, it's now 25 years of doing it. I almost exclusively go femorally. We very rarely do radial procedures. I think the radial fascination clearly exists, in half of the CTO operators in Japan does radially and the other half does femorally. In our centers, we do, most of these cases femorally, and then close it with a closure device at the end. And we rarely ever find major groin complications. So I think that, the folks, those who do a lot of radial procedures, they all really are passionate about it. But we think that we sometimes do one radial and one femoral access, but most of the time we in our centers go femorally.
Yeah, Raj, I would say that I think it makes a lot of sense to do what you're comfortable with, but also really what's going to make the procedure easier. And occasionally, if we're too dogmatic about femoral or I'm a radialist, we can end up trying to kind of force our access agenda on the patient rather than the anatomy dictating things. So, occasionally there's good combinations, biradial, bifemoral, or a combination radial femoral. And if you do that, femoral is probably what you would typically use for your antegrade guide and a retrograde guide radial. But,
and I just want to say that, we started out with 8 French catheters, and I've gone down to 7 French for many of the procedures, or most of the procedures, and combining a 7 French radial with a 7 French groin, sometimes 6 French and so on. But the 7 French really it's a huge difference between 6 French and 7 French. And 7 French is not that far behind the 8 French. So that's why I use also 7 French. But mostly I do 1 radial and 1 femoral. Also saves sort of your back and things like that, so practical issues. Some patients don't really like to have their biradials, afterward the procedure. There's a little bit hindered by that. But so generally 1 radial, 1 femoral, 7 French.
And typically, if you can get a 6 French in, a 7 will go under most circumstances, but it gives you a lot of tactical advantage, irrespective of where you're coming from. So, I think 7 is a pretty good size that will accommodate most things that one needs for CTO.
In addition to the size, the French size of the guide catheter is, I tend to use aggressive curves. And you want to use an AL1 or AL.75 in the RCA. Recently, I discovered the RCA XB, which is excellent guide. They make it only in 8 French, and they don't make holes, so I make the holes for the RCA. For the retrograde guide, you don't need as much support So 7 French is good, but I use EBU4 as opposed to EBU3.5, and I use XB4 or like the extra large curve that will help you during maneuvering and during pushing gears either forward or backward if you go in retrograde. For the radial femoral debate, we need to kind of be mastering all these axes. And as long, I think if we repeat all the radial trials with the new technique of obtaining femoral access with IVUS and fluoroscopic guidance, I think we will decrease the complication rate from the groin significantly. So nowadays, the patient, actually my patient, pick and choose what they want. However, I'm much less dogmatic about what axis. The most important thing is to get the procedure. Those who failed radially because the guide did not sit well, and also tend to follow the CTO algorithm. If the guide catheter is not sitting well and I'm struggling with it, I actually completely reverse, change the axis immediately, and I don't keep struggling, because the guide catheter, the last thing you want to worry about, that the guide catheter is not sitting well or flying off, or basically not moving well. It can dissect your left main or dissect your ostial RCA. So I switched to the femoral. If the radial didn't sit well, or I didn't have enough support, I immediately switched to the femoral.
Just one quick comment related to use of any radial or femoral access is that I think guide extensions have quite dramatically changed the game. And I think when you go Antegrade, a trap liner will reduce you by a couple of French sizes. So you have to take that into consideration, but it dramatically increases your versatility for exchanging wires, etc. And if you're going retrograde, don't use a trap liner as your guide extension, but use a guide liner, because the trap liner is not going to help you get the extra length you need, because the balloon is not is further away. So just antegrade, trap liner, retrograde, guide liner. Guide liner will downsize you by 1 French. Trap liner will downsize you by 2 French.
Very nice, Ashish, and that brings us to the next talk, which is Dr. Ashish Pershad. So Ashish is a phenomenal operator at Banner Goodstand, Director of International Fellowship, and from the good old days of US CTOs has been active, and also very the stalwart structuralist, a fantastic operator. So Ashish, he'll be talking on evolution of CTO Guidewire design, how it has evolved my North American approach.
Yeah, thanks, Parag. Thanks, Raj, for inviting me. And I wish we could have been there in person, but times are weird. My talk is on evolution of CTO Guidewire designs, and hopefully at the end of it, everybody sort of has an option to maybe rethink of how they attempt CTOs in 2020 with current Guidewire designs, and maybe I contributed in some way to everybody's learning, and I'll probably learn something at the end of this as well. So of course, we've all looked at these algorithms over and over again since they were conceived in 2011 on the left panel, and then on the right panel is the Asia Pacific version of it that was published by Scott Harding and Dr.
We are not seeing your screen.
Oh, you cannot see my, are you guys not able to see my screen?
No, you have to share it. I guess it's not sharing.
No, I'm sharing my screen.
Do you have a dual screen setup, Ashish?
No, I don't. Let me try one more time here.
Turn off and turn on again the share screen by that.
Maybe I'll just zoom in.
We do.
What's that?
We can see your screen now.
You can?
Yes.
Okay.
You're seeing him, Parag.
No.
We need to share his computer screen so we can see his slides.
Yeah.
Hmm. Give me a second, guys. Maybe if you guys want to go on to the next talk, and I can.
Why don't we will do that.
Yeah.
Okay.
And I'll get back and figure this out. All right.
Okay, sure.
Thank you.
So it's a great privilege and honor to invite President of the Asia Pacific CTO Club, Dr. Eugene Wu, who is a very well-known CTO operator in Hong Kong. And he teaches the world over in Asia Pacific on how to perform a CTO intervention. He just recently has written a position paper on the reverse card to Antegrade wire access, a guide to externalization, tip-in, rendezvous, and snaring. A position statement from Asia Pacific CTO Club, and that is the topic of his discussion today. I also want to take an opportunity to invite all the APCTO Club members. The C3's relationship with Asia Pacific CTO Club goes many years back, and we have hosted APCTO Club many times, and will continue to do so next year. So welcome, Dr. Wu, and the floor is all yours.
Well, thank you very much, Raj, for inviting me. It's of course much better to come to Florida, but it's also nice to be able to do this. So let me see. I will try to share my screen. So can you all see my slides?
Not yet.
Not yet. Now?
No, we still see you.
You still see me. Okay, let me try share screen again. Share screen. PowerPoint.
We just had your slides up and now they again lost.
No,
It was my slides. I was worried that I'm not going to be able to share, so I shared mine to see if it worked.
Kyle, we see your slides just perfect. Yeah.
It's not so easy to share the slides.
Yeah.
Are you seeing?
When you click on share screen, it will ask you to select, what on the screen you wants to share. So you should be able to see a PowerPoint box.
I can't.
Now actually I see Ashish Pershad's screen.
Ashish, click on.
How about let him go? I don't think we can multiple share. That's the problem. Let me see.
Okay, why don't we go back to Ashish?
Well, you know what, Ashish, I can see your slides now. So why don't we just start with your talk?
Okay, sounds good.
Because we can only share one person's screen at a time.
Got it. Can you guys hear me? Let's try this again. So my talk in the next few minutes is to really go over the evolution of CTO Guidewire designs and how it's changed my approach in CTO PCI for 2020. So we've all seen this algorithm many times. Craig showed it earlier. On the left panel is the original hybrid algorithm, and on the right panel is the Asia Pacific version of it. Bottom line is that I think a couple of things stand out. There's a lot of similarities, but the thing that is we're going to focus on is two parts of the algorithm. The first part is the ambiguity of the cap versus the non-ambiguity of the cap. And the second part, where I think there's been some progress made, is lesion length. So although there's data that supports 20 millimeters as being an arbitrary binary cutoff about wiring vessels through an intraplaque course in shorter lesions, and a high risk of going in and out or subintimal in lesion lengths that are longer than 20 millimeters. That number and that data is actually old data from the Cleveland Clinic, and with some IVUS correlation at that time. Hence, we've now need to relook at that in 2020 with available technology and improvement in Guidewire technology. But at the same time, as Jay mentioned earlier on, we can't compromise safety. Patient safety and outcomes have become absolutely vital, especially when CTO PCI is being is under such tight scrutiny from the general cardiovascular community and even from our interventional colleagues that don't do this. So keeping both those factors in mind, I think we need to come up with a strategy that improves efficiency, but at the same time doesn't compromise on safety. So with that background of information, let's look at this angiogram. And on the left panel, you can see a diffusely diseased right coronary in a patient who's had previous CABG with predominant filling of the distal vessel through collaterals from the lima and an excellent distal target, but a lesion length that clearly is in excess of 20 millimeters in a vessel that's moderately calcified and on an angle right after that takeoff of the RV marginal. In the past, this is a slam dunk retrograde case if you have a good retrograde option. Obviously, with the emerging data that retrograde PCI, especially through a lima, potentially has increased risks. And the absence of ability to go retrograde, if the skill set is lacking by the CTO operator, then a plan B in most instances here would be a high-end ADR if you can do a stick and swap just proximal to the bifurcation. Or if you're not so lucky, then maybe a bifurcational, an ADR approach into one of the branches and then potentially a mini star into the other branch to optimize the outcomes. Would any of the panelists disagree with this being a primary ADR/retrograde case?
Not at all. I mean, you're weighing competing risk of using a high risk lima versus an alternative strategy that you just described. I think that's it's smarter. The scales tip you to doing what you're presenting, I think.
Yeah. So on the right panel, we obviously use the lima for visualization, and here you have your AL guide, and I went straight ahead with a game plan to get past this whole ambiguity and long segment with a knuckle. And you can see that the knuckle very rapidly brought us to the distal cap. And here I was sitting at the distal cap, really close to the bifurcation. And in the past, we would bring down a Miracle 12 and bring down a Stingray and contemplate use of a really advanced stick and swap maneuver. But in 2020, I recently had access to the Gaia Next family, and I thought we'd give it a shot to see if we can do a targeted reentry with the Gaia Next. And as you can see in the right panel, I was successful in a fairly short period of time to be able to get into the posterolateral branch proximal to the bifurcation with the use of the Gaia Next. So, I think it made me, this was the first case I had done, and it made me with the Gaia Next. And so it made me really look into this a little bit deeper to see if this was a real thing. So investigation into the Gaia Next, looks at, well, how is this different from just the Gaia? Well, a couple of things. Number one, conventional wires have a ball tip, and this Gaia Next family has a micro cone. And what that does is it allows for easier engagement and possibility even of creating alternative reentry routes. Although obviously that's a big stretch and a big comment, but bottom line is it's easier to engage the proximal cap, or in this case, the distal cap, due to this presence of a cone at the tip of the Gaia Next. Of course, like other Gaia wires, they come with a 1 millimeter pre-shape, which is great for increasing your shape retention and for fine movements within the lesion. But the other big thing with the Gaia Next is this concept of X-strand coil. And I'll talk a little bit more about that. But the bottom line is it prevents the wire from getting stuck in calcified and long lesions, and also prevents tip breakage. And all of us have seen our Confianza Pro 12s and our Jjyan wires break in. And the Act 1, of course, is maintained in terms of its ability to provide us with great torque transmission and durability of the tip. So those are some of the theoretical advantages of the Gaia Next. And so next, let's talk about the penetrability of these wires. So like I said earlier, the safety comes first. And compare this with all their old family of entire set of Asahi wires, starting with the Ultimate and then extending to the Gaia First. You can see that the next one has the tip load here is obviously in kilogram force per inch square. So the numbers are a little bit unfamiliar, but bottom line is that compared to even say, for example, a Confianza Pro 12, which has tip force of 157.7 kilogram per inch square, the Gaia 3 Next has a much higher penetration force of almost 100 kilograms per inch square higher. And so similarly, the Gaia Next 2 has a much higher penetration force than a Pro 12 or a Confianza Pro 9. And so once you understand that the penetrability of these wires is also a little higher, it allows you to basically manipulate them with the degree of caution that's necessary to prevent you from having an outcome that's less than desirable. So let's talk once again about this X-strand coil. So most conventional wires have a single coil. So what X-stranding does is basically it creates a rope with multiple wires and several ropes of wire creating a coil. And like I said earlier, what allows that is that it prevents this wire from getting trapped and increases our maneuverability inside more complex lesions to prevent guide wire trapping. And the other thing it does is it prevents the risk of the guide wire actually breaking, which also we see quite frequently in the most complex and the highest of JCTO score cases that we've been attempting more and more at our center. So going back to our case one, as you can see, I mean, it was a spectacular outcome with tremendous runoff in both vessels, with a really landing of the stent right proximal at the bifurcation with really no need to encroach into the bifurcation at all, and a healthy PD and a PL. And this was done with antegrade wire escalation, which I don't think I would have thought would have been successful without the ability to have the kind of control I had with this wire tip. So let's take a look at another case. Unfortunately, I have 3 right coronaries just to, these are all cases that I've done in the last 4 weeks. This was a case that again looks, if I were to follow our North American hybrid algorithm from the past, this is a patient who's got minimal left-sided or intermediate left-sided disease, but once again, a long CTO of the proximal right coronary with the diffusely diseased proximal segment and poor landing zone. And you can tell from the dual injection in the AP cranial projection that, you know, there is a reasonable zone before the bifurcation that could be considered for ADR. And so, or a potential for doing this retrograde obviously is still a viable option given the collaterals you have from the septals. So obviously I would treat the mid-LAD intermediate lesion first before I chase down the retrograde septal. But bottom line was that this is again one of those cases that is either an ADR case or a retrograde case if we were to go with the algorithm. Would you agree, Cal? This is the approach you would follow?
Yes, absolutely. And it's like, as long as you have an option, like all the options are available to you.
Yeah, but antegrade wire escalation wouldn't be your go-to choice in a case like this, correct?
No, absolutely. You have a long, more than 20 millimeter occlusion, tortuous anatomic ambiguity. So where are you going to poke? So you're going to have to transverse this segment with something that's safe.
So here we are, like at the distal, right at the proximal cap at a microcatheter, and you can see that this is the guy next to, and this is the guy next to with in an RAO projection, and you can tell that you've engaged the cap and you've actually made some progress. In the past, we would use a Pro 12 to do this, and then de-escalate to a Pilot 200 or a Mongo or an XT, and knuckle quickly down to the distal cap and re-enter, right? I mean, that would be our strategy in the past, and we've done tons and tons of cases like that. But this, I think, is this advantage of Gaia 2, some degree of directionality control as well as some deflection control, where you can change the course of the wire by rotating the tip and then use deflection to track the wire. And I think you'll be surprised. I was very pleasantly surprised to see, as you can see in this panel, how easily it was able to track that diffusely diseased segment on a band and was able to get into the distal segment, and once again, staying intraplaque and not using any kind of complex parallel wire type stuff, but just staying with a single wire microcatheter approach, which is familiar to most operators. And I think was able to, once again, surprisingly get a good result with just antegrade wire escalation.
Ashish, I can't help but ask you, do you use the Gaia Nix with torquer or with no torquer?
No, I never use a torquer at all. As you know, you've worked in my lab before. I'm a hand with non-torquer guy. So, I mean, I just think that that's a personal preference, but I have basically, I don't use torquers at all unless in the very rare instance. So no, I don't use a torquer with this.
I just want to make sure, when you advance the Gaia Nix, what kind of the tactical feedback, or did you start doing, did you do multiple retrograde injection to make sure that you're on a course, or there is some tactile feedback?
No, there's clearly tactile feedback once you're within the plaque. And I think, of course, all the concepts that we've learned all along, I don't want to by any stretch make a case that this is a safe wire. This has all the risk associated with wiring long segments like every other wire. So, you have to take multiple views, orthogonal projections, retrograde tests, et cetera, to confirm that you're in the architecture of the vessel. So again, last is a case 3 post-cabbage right coronary with limited options, once again, showing a collateral through the PDA. And this is really the only visible collateral there was. I couldn't really visualize the posterolateral branch at all, either through the native left or through all vein grafts were occluded. And so this was a case where I was potentially just thinking that my only strategy here would be to come down with a knuckle past the cap and do sort of a mini star into the posterior descending, and then or re-enter into the posterior descending with an ADR strategy, depending on where I got in, and close to the distal cap. But my likelihood of success with ADR in this instance was not high, because I felt like the vessel was diffusely diseased and the PDA was small. And we've all had cases where we struggled with ADR and in the end get frustrated and end up mini starring the vessel. And in this case, since the absence of a posterolateral branch and there was only one branch, I was quite comfortable going into this with a strategy to mini star the PDA. And so here we go. We have an XT here, and you can see that I've sort of successfully got in. And then on the right panel, after we got in and took care of the PDA, I noticed that there was faint filling of the posterolateral branch, and it was a higher origin of the posterolateral branch. So I brought down a dual lumen catheter and then was able to probe this guy next with the Sasuke dual lumen catheter right at where I thought there was contrast opacification of the posterolateral branch. And again, with the dual lumen catheter, I got pretty amazing tip control and was able to wire this posterolateral branch and was able to actually do a bifurcation strength strategy and take care of both the PD and the PL, and ultimately got an outcome that I thought was acceptable and surprisingly good, given the fact that there was no previous visualization of this PL at all. And I think in turn, this probably made a big difference in terms of outcome for this patient, in terms of longevity. So the takeaway again for me is that I think the Gaia family of wires have significantly increased the likelihood of successful antegrade wiring. However, the prerequisites are a non-ambiguous cap and a known anatomical course of the vessel, either by CT or good retrograde angiography. Absence of severe calcification, of course, is an important consideration. Failure to meet these prerequisites will definitely increase your rates of perforation with these wires because of their high penetrability. Lesion length of 20 millimeters, I think, is no longer rate limiting length for wiring as long as you follow these above mentioned prerequisites of non-ambiguity and understanding of the course of the vessel. And I think over time, as we get better with IVUS interpretation, our success with antegrade strategies will continue to improve. Thanks for your attention. Raj, I hope I didn't overcross time.
No, you did just fine. Thank you very much. You know, and I was telling you a couple of weeks ago that I had recently hosted, you know, before COVID, some Japanese colleagues, and we had 3 CTOs. And with the Gaia family, you know, we did all 3 cases with a very simple antegrade crossing without much in the way of trouble. So, you know, as I was telling you, that we find that our antegrade success rate has substantially gone up with these new wires. Any comments from other panel members?
Yeah, Ashish, those are great cases, quite spectacular, actually. I would say that, at least on the first 2 examples, you had a large side branch at the cap, and I would certainly advocate the use of IVUS guided puncture, because I think that would really dramatically improve the success rate with these new wires. They're amazing wires, but if you can puncture correctly, that even helps more.
That's a great point. For a side branch,
I think that's a great point, yeah.
Yeah, CTO, nice to look at it with an IVUS to select the spot where you're going to enter with a Gaia second, third, next, whatever your weapon of first choice is.
I actually used the Gaia third next for stick and swab, very tortuous RCA distal, not much calcium. We did an ADR strategy, and I took the Gaia next just for kicks and giggles to see how it functions, and it actually functions really good. I could have probably wired with it. However, I said, okay, I'm gonna swap, because it was very kind of bendy curve, and it worked like magic. The thing about the Gaia Nix, I think, I've been using it too, that the deflection of the wire from where you wanted to send it, that's what causes us to kind of fail and go into places. I think we have much better control where we push this wire, and that contingent on understanding the anatomy really well and you knowing where you're pushing. So previously we know where to push, but whatever wire you push, either it's gonna poke straight forward or will go in a place, will deflect. This Gaia Nix is much better controlled. And it's
I'm curious to get Craig's view on this, because I mean, you know, when we started this, I think that 20 millimeter came from you and Bill and our original 2011 meeting. And I think I'm very curious to see what you think about, I hope we're not regressing by promoting something like this. And it's something I worry about, especially when it comes to, you know, efficiencies and risk of these type of procedures.
Yeah, you know, I mean, look, I think it would be, if we don't have a commonality of what we're speaking about collectively, to each other in the audience, it probably is a little bit of a regression. But I don't think that this talk is regressive. I think what you're trying to present is, hey, we've got new technologies and we've got new tools. That's what I've heard. And yeah, I think 20 isn't a magic number. We kind of pulled it out because we knew longer is harder than shorter, and use JCTO to say, okay, 20 millimeter. But you know, that number could be 30, it could be 40. You know, I think the lesson here is use the right tool at the right time, but don't take it beyond its limits. So if I've got a sharp, stiff guide wire, I need to get into a cap, and then I'm going to de-escalate and change strategies. But you know, you've shown some really excellent examples of how to use that tool at the right time and not ask any more of it than it's capable of doing. I think my concern, and what we tend to see in CTO PCI, is, oh, I made it, let's take a confidence of 12, for instance. I made a little bit of progress with it, so why not keep going? and keeping going over 70 millimeters with a Pro 12 and following it with a microcatheter could be hazardous. So I think what we're doing is we continue to reassess and say, hey, look, we've got better tools. For this purpose, I'm using this tool, and then I'm going to switch to a different tool for a different reason to accomplish a very specific goal in the procedure. So we just want to keep our minds open and be flexible.
Thanks, Craig. So we're a little bit behind, so I'd like to now invite Dr. Eugene Wu to start his presentation.
Okay, I'm going to see if I can share my desktop to you.
Yep, it's working.
You can see it. I think
I see
thank you very much for inviting me.
Yeah, thank you. Yeah. There we are.
So this talk actually suggested by me from the paper that we recently published. The original idea actually came from Paul Gao, who's one of the directors in APCTO Club, and he says, why don't you write about this very, very, very small part of the retrograde procedure from after you succeed on reverse guard till you get the antegrade wire in? And I said, nobody's going to publish this, but I eat my words because this happens. So today we're going to talk about from reverse guard to antegrade wiring. Usually when we've successfully done reverse guard, we've succeeded in the CTO PCI and we're done. So we usually don't even think about this part of the procedure, but still sometimes we fail at this point, or we spend a lot of time getting from reverse guard to antegrade wire access. And sometimes we create horrific complications during this part. Really, the failure of this part can be condensed into several specific failures. Number one, failure to wire through the proximal vessel. Number two, failure to push the retrograde microcatheter across the CTO. And of course, number four, failure due to complications. So this talk is very specific in dealing with these four failures. So let's quickly review what we usually do. And I think this is probably what most of us are doing nowadays. So when we get through the CTO, you see we wire the retrograde wire here, you see an XTA into the retrograde wire into the antegrade guiding. So you can see here an XTA going to the antegrade guiding. Then we do next is we push the wire up and we push a balloon down, a trapping balloon from the antegrade guiding, and we inflate this balloon. This balloon then traps the retrograde wire, which gives us enough support to push the retrograde microcatheter, in this case a Corsair, into the antegrade guiding catheter like so. Once we've done this, we remove the retrograde wire like so, and we replace it with an externalization wire, in this case an RG3. After that, we take it out. Now, and then we have externalization. So this is a video demonstrating how we do it.
So we have here the
so I'm not going to talk, I'm letting him talk.
retrograde guiding catheter and the antegrade guiding catheter. And we want to demonstrate the process of wire externalization. So when you're doing your CTO and you manage cross the lesion, you'll try to wire the antegrade guiding with the retrograde wire. After you successfully wire the antegrade guiding, you place an anchor balloon on this side to the position to trap the retrograde wire by inflating this and trapping the retrograde wire. With this, you have great support to push the retrograde microcatheter across the CTO and into the antegrade guiding. At this point, we usually recommend you release the trapping of the guide wire and push the balloon forward a little bit and trap instead the retrograde Corsair. This stabilizes the position of the retrograde Corsair as well as stops back bleeding from the antegrade side. Then you remove the retrograde CTO wire and instead replace it with an RG3 wire. So we push the RG3 wire all the way through the retrograde system, and under fluoroscopic guidance, we check when it begin to reach the antegrade guiding. When we can see that it almost reaches the antegrade guiding, we will put the wire introducer in parallel to the anchor balloon. At this point, we can loosen the hub and undo the Y connector, and then back the Y connector off the balloon. We keep pushing the retrograde RG3 wire until we see it come out of the antegrade hub, like that. And then we get hold of the wire tip and we place it inside the wire introducer. And we connect the wire connector. We push the retrograde wire more so that it now comes out of the hub, like so. And then we remove the wire introducer. And then we're set up now, if we deflate the anchoring balloon and remove the anchor balloon, we allow bleed back to make sure that there's no air trap. And now we have access through this wire to the antegrade side.
So it's important, I showed this video, it's important to pull back the retrograde guiding before we back out the retrograde microcatheter. Otherwise, you have a danger of sucking in the retrograde guiding and damaging the left main. So I put this video in just for that. And so after you externalize, you can then balloon and IVUS and stent. So it's easy. So the first problem, apart from this usual method, is we can't get through the proximal vessel. This is usually because we use the stiff retrograde wire and it's going into the plaque or the subintimal space after it's crossed the CTO in the proximal vessel. It's more often in the right coronary that you have this, especially if there's a tortuous proximal vessel, especially if you've done balloon dilatation in the proximal vessel. The solution is to use a guide extension catheter. Ever since we had guide extension catheter, this problem has almost been solved by doing this. There are a couple of tips of using this. Usually because you don't have much antegrade wire inside the vessel, you need to use a balloon to drag the guide extension catheter into the vessel. So I use a 2.5 or 3.0 balloon to inflate it in the vessel and drag the guide extension into it. 7 and 8 French guide extension catheters are better. They are easier to wire than 6 French. The second problem, failure to wire the antegrade guiding catheter. The important thing to recognize here is that manipulation of the guiding catheter is more important than manipulation of the guide wire. I repeat myself. Manipulation of the guiding catheter is more important than manipulation of the guide wire. Try to move the guiding over the wire. So this is a live case I did recently. And you can see here it's an ipsilateral septo-septo-collateral, and it's quite a sharp septal bend, so we don't have good retrograde wire control. And you see what happens? I push the wire forward and it's beneath the guiding. So instead of changing the position of guide wire, we change the position of guiding to cap it over where the wire is, and we push the wire in exactly the same manner, and you can see you can wire up into the guiding. So move the guiding catheter, not the wire. In right coronary, this often means we got to go to RAO view and clock the guiding so it's coaxial. Often a JR guide is easier to wire than an AL guide, and so sometimes if I'm using an AL guide for RCA CTO, I'll change out for a JR when I get to this point of the procedure. If we cannot wire it, changing a softer wire such as Xeon Black will be easier, but the problem of course is you can't change unless you get the microcatheter across the CTO, and sometimes that is difficult. So how do we do that? We do it by sticking the retrograde wire as far up the aorta as possible, like so, and also putting a balloon in the proximal part of the vessel and anchoring it up like so. This will give you enough support to push the retrograde microcatheter through the CTO in most cases, not all cases, but most cases. Once you push the retrograde microcatheter across, like so, you can then change out for a Xeon Black wire, which will be easier to wire in. What if you can't push the microcatheter across? Then in this case, our algorithm suggests we change the retrograde microcatheter, because sometimes the tip of the corsairs become fatigued after going through the septal channel and across the right coronary and across the CTO. So the first approach may be to change a new retrograde microcatheter, which might allow you to cross. After you cross, of course, you can change a soft wire, such as Xeon Black in this case, and you can easily control it and wire the antegrade guiding, and then the same thing, you just balloon anchor it and push the retrograde microcatheter across and externalize, and you can do IVUS and whatever you want to do. So what if you can get through the first two problems, but you cannot get the retrograde microcatheter through the CTO? What can you do? So a lot of people will go, well, why don't you just snare the wire? Then you have a lot of pull, and you can pull the snare wire into the guiding and anchor it, then you can cross the CTO. But the problem is how to snare safely. So the great danger of snare is that you kink a very stiff retrograde wire like a Conquest 12, and after you kink it and put it into the guiding, you cannot release it. So in our APCTO club, we've discussed among our directors, and we recommend using the Sumi 2G snare. You might know this from Sumi Suchi. We use it because it's widely available. As long as you have a guide extension catheter, a balloon, and a workhorse wire, you can make it. 2, you can make a very big loop to capture the retrograde wire. And 3, you can release it by deflating the balloon. So wire entanglement is far rarer with using 2m2G. So this is a case you can see how big you can make the loop. And basically, it's quite easy to make the loop. What you do is you just push out the wire from your trapped corset. You can see such a big loop. And then if you pull back your retrograde wire and just push it forward, because you've got such a big loop, it's going to capture the retrograde wire. And then you just snare it back up and you can actually capture the wire easily. And this is a very good advantage of having a sort of flexible sized loop. Here's captured and here's pulling it into the guiding. And I usually only put it a little bit into the guiding and then I release it so that I don't buckle the wire too much and end up trapping it. And now I should use a balloon, the same balloon that I've been using to do the SUMI2G to anchor the wire in the guiding, and I can push across. So always deflate the SUMI2G snare in the guiding so that you don't kink the retrograde wire. Finally, rendezvous technique. Why do we need to talk about rendezvous technique? Well, historically, those of us who are old and has been doing retrograde for more than 10 years will know this. We used to have very terrible wires. We used to externalize pilot 200 wires, which are 300 long, or used rotor wire. You remember externalizing the rotor wire. The longest part of the procedure was externalizing the rotor wire. You get blisters on your fingers doing that. So back in those days, it was useful to use rendezvous. Of course, nowadays with guide extension catheters and with RG3 wires, we rarely need rendezvous, and it's become kind of a very niche, forgotten thing. But I think still there are some roles for rendezvous that is necessary in 2020. And I think there are 4 main roles. Number 1, and it's quick establishment of antegrade trap. If you're doing a large collateral channel and you're getting some ischemia, or you've got a complication in your channel and you need to bail out to antegrade, this is an easy way you can try once or twice to get antegrade access. So when you bail out, you still have an antegrade wire. Second is a method to overcome retrograde microcatheter can't cross the CTO. And I'll explain why this is useful. Third, if there's still some patients, especially my friends in Northern Europe, they're doing these 7'8" Norwegian men, and even with a short guiding catheter and a guide liner, you can't reach, so you need to rendezvous. Some of my friends do 40% rendezvous in their retrogrades because they are working with 7-foot giants. And of course, the single guiding, if you want to be cool in a live case, you're doing a single guiding for ipsilateral collateral rendezvous is necessary. So the rendezvous technique, basically at the outer side of the curve, that's where you can get both wire and retrograde antegrade microcatheter to connect. So always wire to the outer side. This is a very silly case I did many years ago. I've already got the retrograde microcatheter inside the antegrade guiding, but I want to demonstrate that it's at the outer curve that I can easily do it. So I actually had a video, which I've lost unfortunately, in which I keep wiring one way to the other way back and forth 4 or 5 times just the first time to demonstrate at the outer curve of the guiding catheter is easy to do rendezvous. So why do we use rendezvous for uncrossable CTO? How do we do it? So this is another video demonstrating how we do it.
So here we're demonstrating the technique of tip-in. This is the retrograde guiding. This side is the antegrade guiding. We are just manipulating our retrograde wire into the antegrade guiding. After we successfully done this, we place the antegrade turnpike gold, in this case, microcatheter, into the guiding catheter. We try to manipulate the retrograde wire at the bend of the antegrade guiding by wiring into the antegrade microcatheter. When we successfully got tip in, what we must do is to gain the most amount of force for antegrade delivery. So we should push the retrograde wire as far as possible, leaving only 5 centimeters or so outside. And we should secure it by placing a torque device onto this wire and making sure that we torque it tight against the hull of the retrograde microcatheter. Then we can make sure we have adequate backup for the antegrade side. If we need to, use a guide extension catheter or side branch anchor balloon. And we can then try to turn the antegrade turnpike gold to follow the path of the retrograde wire to go through a lesion. One other alternative we can do is we can connect an deflator and pull negative on it. This will give more pull on the wire to give it more power to talk through.
So since that video, actually, Canvas has shown me another trick, which is you can put in a Miracle 12 wire into your Turnpike Gold. That's going to give the body more strength to push through. That turns out to be even better than giving negative suction. But it's very important, if you can't cross the retrograde microcatheter, to really increase the backup force of your Rendezvous antegrade microcatheter. Because if you can't cross it from retrograde, there's a good chance you need quite a lot of force to cross it from antegrade. So it's not always successful, this method, because the CTO is tough. But the reason we do this is because the alternatives are not good. So if you can't cross the retrograde microcatheter, what can you do? You can push very hard, but of course, there's a chance that you risk rupturing the channel. You can take out the retrograde system and change for a small balloon to jam in the retrograde side. Again, there's a chance of risking channel rupture. You can give up the retrograde wire position and do retrograde knuckle and do external cap crush, but you've given it up, and also you have a very difficult reverse card after this. You can try to change for a rotor wire, but there's a chance of losing the wire position, and there's a chance the rotor wire won't cross. So all the other options carries a risk of not being able to get the wire position back. This Rendezvous method, you can try it. It will work, I think, probably in about half the cases. And if it works, you haven't lost wire position, and it doesn't take very long to try. My favorite method now is fast becoming changing for rotor wire, because if you have a rotor wire across the lesion, you can almost always do it. And the method I use is the antegrade rotor wire chasing retrograde wire technique. So this is quite a nice technique to do. So you see, I already crossed retrograde here, but I can't get the microcatheter to cross from retrograde. So what I do is I put an antegrade rotor wire on the microcatheter very close to the retrograde wire. And I pull the retrograde wire millimeter by millimeter back as I push the antegrade rotor wire millimeter by millimeter forward, following it. And then you can see I can put the rotor wire down to the distal LAD, and then I can burr. So this is a 1-2-5 burr. And this is a tough CTO. You can see that despite my less aggressive burring here, I'm not making any progress into this. Oh, you have to pull back the retrograde system because you don't want to burr off the tip of the retrograde microcatheter. So make sure that's in the septal. So more aggression. When it doesn't work, use more aggression. So you can see much more aggressive burring style now. And we could actually pass through this. So this would be my preferred technique if you really got stuck. So try off the Rendezvous technique, if not turn to rotor wire. So in conclusion, the technical success after reverse cut is very high. Most of the time, we don't even have to think about this part of the procedure. But there are some rare cases where this gap between reverse cut and antegrade wire access becomes extremely difficult. Usually, the operator is tired by the time they've done reverse cut. So it's important to have very focused methods to overcome failure so that you don't get more tired and to get over this part quickly. So we provided a guide, the APCTO Club has provided a guide of how to do this and how to overcome the problems and how to move quickly past this part of the procedure. And I hope this is helpful for those of you who do a significant number of retrogrades, and it's useful for us to have this documented in a paper. Thank you very much. Oh, I wish you success.
So this was a great talk, Dr. Wu, and the complicated techniques, and as you get more into the retrograde techniques and whatnot, and many times there's a sigh of relief when you cross the lesion. And so many CTOs, as all the experienced operators can tell you, that that's, well, sometimes it's just a 20% of time crossing the lesion, and sometimes you end up spending 80% of time in finishing the case. So any comments from the panelists?
This is really very awesome techniques you demonstrated. It's a most important thing not to get stuck in a failed mode. So this is like you have this, you add another arrow to your quiver, and just you have to keep changing. So I remember the days when we stuck trying to cross, integrate the wire cross, nothing would cross, and we have an algorithm for it. And the most important thing is to move through that algorithm really fast. Thank you so much for this talk.
It's a great talk. And I think the evolution of the microcatheter is going from Corsair to Corsair Pro to Corsair Pro XS, and the availability of the other catheters also, I think that has made a huge difference. And the catheter fatigue is another huge factor that many times you're struggling, you simply change the catheter and you move forward.
Yes, I think the problem is wires for crossing the channels become so much better. So although the retrograde microcatheters become a lot better, they are still having trouble catching up, because now we can cross channels that we couldn't cross 5-6 years ago. And now you need even better microcatheters. The XS, which we've had recently in Hong Kong, is doing quite well. Stronger, I think, even than the Turnpike.
So, totally. So that was a great talk. And in the interest of time, we'll move forward with the next talk. This is part 2 of our CTO symposium. The next speaker is Dr. Mir Basir, emerging CTO operator, trained by Dr. Alaswad, is a fellow. And welcome, Dr. Basir. He's going to talk about microcatheter designs, which fits right into the transition from Dr. Wu's talk.
Fantastic. Thanks for having me. Can everybody see my screen?
You are on. We can see.
Okay, great. Thank you, Parag, Raj, for having me. I really appreciate the opportunity. My name is Mir Basir from Henry Ford Hospital. Below is my contact information if anybody has any questions, but I'm basically going to talk to you a little bit about microcatheter design and why microcatheters are must in both complex PCI and CTO. These are my disclosures, all relevant to hemodynamic support, nothing for what I'm going to disclose today. I do want to just take a minute to thank Sarah Bailey for giving me some of her slides to help me with this presentation. So really for the audience, this is the basics here. What is the purpose of a microcatheter? It's to facilitate wire exchange, maintain wire position between wire exchanges, and then to maintain wire access beyond a lesion. And so these microcatheters are going to give you the opportunity to improve your wire torque. They're going to give you 3 times more support typically and penetration power to your current guide wire. And then, as Craig has said over many, many years, it's really the most important thing in CTO PCI is to kind of move the base of the operation. And so microcatheters, guide extensions are going to be your savior in trying to move the base of operation and ultimately get a very successful procedure. When you're early and starting off in this process, it's really important to know what you can and cannot do with a microcatheter. We had a early operator passing a microcatheter in a small channel, not knowing where they were and causing a perforation. So it's always important to know where you are, advancing over a guide wire, not to inject a catheter without aspirating so that you're not injecting bubbles into that microvascular bed. Your movement of your microcatheter should always be guided by fluoroscopy. And what's important also is that these microcatheters all have coatings around them to kind of help reduce the friction. And so you really want to not wipe these down with a lot of gauze, just leave them in some heparinized saline so that you're not taking off the hydrophilic coating. There are 2 major classifications of microcatheters, torqueable and non-torqueable catheters. Primarily for most CTOs, we're going to have an advantage of using torqueable catheters that can be rotated both clockwise and counterclockwise. There's definitely nice videos on YouTube for early operators on how to do this. I won't get into those details, but generally spinning in clockwise and counterclockwise fashion without building up too much torque, reversing between clock and counterclockwise as well, so that you're able to kind of change directions and allow your torque to be disseminated to the tip of the most distal aspect of that microcatheter as well. And then there are non-torqueable catheters as well that you do not rotate because if you do so, they'll tend to kink and trap your wire. So microcatheters that you do rotate, Boston makes the Mambas. We have the Turnpike family and Corsair family from Asahi. Cardiovascular Systems has produced a Teleport microcatheter. And then similarly, with each of these companies, microcatheters that you only push. Caravel and Fine Cross are probably the most common ones. You have super cross catheters with an angled tip, and then dual lumen catheters as well that we'll kind of briefly discuss. So most of these catheters have dual coiling on them, and coiling is important here for improved flexibility, torqueability, and to prevent kinking from occurring. So these directions of the coils actually give most microcatheters a slightly more benefit by going in one direction over another. And so the Boston family, the Mamba family works best in a clockwise rotation. And then the Teleflex family works similarly in that way. Asahi works better with a counterclockwise direction. And then the Teleport has no specific recommendations. You can go in both directions. So why is this torqueability so important? When you're going through a retrograde CTO, for example, through septal collaterals, which are tortuous, and then heavily calcified right coronary artery, potentially with calcification and significant tortuosity. For every millimeter of surface area that you have, you're having an interaction between the wire, the microcatheter, the CTO, and the vessel. And so all of this creates a tremendous amount of friction. And so to reduce that friction, you actually are able to torque microcatheters, which allows you to rotate and move your body of equipment either north or south to basically have a successful procedure. So it's really, really important because the torqueability allows for you to overcome the friction built within these systems. And we all know that when you can't move your equipment, you really start to get into a stuck mode, and you really need to change strategies at that time. So these microcatheters now that have become developed, so we talked a little bit about, the Corsair Pro, and Corsair XS. Now, these microcatheters have just a tremendous amount of technology associated with them. So they're usually typically a dual layer bidirectional coils, which give a lot of kink resistance, a lot of ability to torque these catheters. They're getting to be lower and lower profile as well, so that they are able to navigate through these micro channels to a greater extent. And so we're really in an era, I think, where we really have a tremendous amount of technology and tools to be able to help us accomplish our feat. So let me give you an example here of a case. This is a heavily calcified obese patient. I know that it doesn't look so good on your screens, but it doesn't look so good on my screens either. It just really obese patient. You can see here, originally tried Antegrade, were just too long of a lesion, too heavily calcified, and so ultimately ended up going retrograde. And you can see, pretty simple connection here. So we wired across with a Jjyan, and ultimately my retrograde catheter here was a Caravel. So really, I'm just going to be able to give a lot of pushability. And so you see in this very, 60 centimeter or 60 millimeter of occlusion, heavily calcified, I picked the wrong microcatheter, right? I needed torqueability here. The lower profile of a Caravel was helpful to get through the septals, and I quickly got to the distal cap, but getting through the CTO was really a pain. And so all of the examples of Dr. Wu's previous lecture are just running through my mind here. But honestly, I should have just quickly switched out for a torqueable microcatheter, and it would have made my life a lot simpler. But I spent 30 minutes getting more and more support till finally that Caravel did ultimately get through, stented back after externalizing with an R350 and got a good overall result. So really, that's the bottom line, right? Whenever we're picking our equipment here, we're making different trade-offs, right? So a Corsair, fine cross, these smaller non-torqueable microcatheters have a lower crossing profile, able to navigate potentially through small turns and bends very easily. However, the ability to not be able to torque makes them difficult to use in calcified, tortuous vessels at times as well. And so whenever we're picking our equipment, it's really important to think about the trade-offs and what we're looking for and what we need. And so lower profile devices have some advantages. More torqueable devices have other advantages as well. And so there's really, in terms of classifications of microcatheters, 3 primary uses. So one is just a transit catheter. You're really just swapping out wires in complex PCI, for example, switching out to a rotowire, for example, the rotor blade, or do orbital atherectomy. You have braided wires, which improve your flexibility and give you the ability to cross through microchannels and a lot of tight tortuosity. And then coil and braided microcatheters, which are really, you know, considered to be workhorse microcatheters for CTO PCI, where these coils give you the advantage of not only more torqueability, but also prevent kinking of the equipment so that we can have overall successful procedures. And then the last kind of style of microcatheters are really supportive catheters. So Turnpike Gold, for example, which has a gold tip, Tornus, which is stainless steel, to help to really be able to improve your pushability, mostly through an antegrade plane. And so as we're deciding through all of these vast amount of microcatheters that we have, we're really just asking ourselves, what are we really using it for? And I think the majority of us are going to be kind of fitting into this a braided dual lumen or a dual torque coil to be able to help with our success in CTO PCI. You can see here that there's clear differences in torque between a fine cross and Corsair, for example. You're going to get more and more torqueability as you add these coils in place. So I'll be extremely brief here about how to use each of these quick microcatheters. So a fine cross is really just an exchange catheter, very low profile. You're pushing and pulling, and it's helped facilitating wire exchange. In terms of the Turnpike family, you have a Turnpike spiral, which has these outer coils, which are really helpful in engaging a proximal cap. And then to go one step further, you can use a Turnpike Gold with a gold tip. It's important in the gold pipe, when using a Turnpike Gold, really to understand the directionality of the coils and the tips. And so to remove the catheter, you want to twist in a counterclockwise manner. Otherwise, you risk actually dislodging the gold tip, which has happened to us a couple of times as well. And then probably my favorite catheter in this family is the Turnpike LP. Again, a dual coil. It tapers down to a very low 2.2 French crossing profile available in the standard 130 and 135 lengths. New catheters from Boston include the Mamba microcatheter, which has this kind of staged tip, which also helps in terms of deliverability, and then coils which really come out to 1 millimeter from the tip, which again improve your torqueability and transmit torqueability all the way to the tip. And really one of the greatest advantages of using this catheter is that you don't risk the tip actually fracturing or breaking off. The same can be said for the Mamba Flex, which we've had good success with from a retrograde standpoint as well. You know, my go-to microcatheters, typically I use a lot of Asahi microcatheters. So nowadays, the Corsair Pro and XS, you know, same basic functionality with a really soft tip that I think is very advantageous in many circumstances as well. So then there are definitely these supportive catheters, both the Tornus and then the Turnpike Gold, which I've mentioned as well, which give you a lot of ability to push through lesions. I think that is kind of fading less and less in terms of importance as the microcatheters have more torqueability, but is an important tool to be able to use indefinitely in certain cases. A microcatheter talk wouldn't be complete without talking about the supercross catheters, which have essentially a curved tip on the end. When I typically use this, I tend to go directly to the 120-degree angle because I'm able to mostly work with my wires and other directionalities without needing of a supercross. What's important here is that when you're using stiffer wires, this angle is actually, you know, typically straightens out a little bit. So even when we use the a 120 and you have a wire through it, it kind of straightens out and it gives you that nice 90-degree bend. But it's important that once you engage into that side branch that you're trying to get into, the tip actually tends to hinder you from passing this microcatheter, and then there's not a lot of torqueability as well. So it's important to know. So I'll end here with just talking about dual lumen microcatheters. So really the first ones that we had used were the twin pass family, and now the twin pass torque. And these microcatheters give you the ability of having an extra side lumen in an RX fashion, which allows you to pass a second wire through these lesions, which can be tremendously helpful in many circumstances. Now, where that's gone to now is just a quick case example of a very heavily calcified, tortuous RCA, non-CTO. As soon as we get our gear in a couple of weeks ago, let the fellow try to wire this, we lose visualizations. Again, this was not a CTO, not a lot of robust collaterals from one side or another. We ultimately, with I think a Corsair Pro, get 2 wires into the PL system, but not much more than that. And you know, the newest family of microcatheters is the Suzuki microcatheter, which has a Corsair tip and a dual lumen example as well. And you can see, I mean, with just some very quick passing, the Suzuki is able to get all the way, you know, past this calcium, past its tortuosity, right up into the PDA. We're able to quickly wire this, balloon it, and then ultimately you see a very easy and quick results. And so these microcatheters are a must for those of you who are early in your CTO experience. You know, it's very easy to use these products in complex PCI as is. And so, as I mentioned, the Suzuki catheter has a soft tip, similar to a Corsair tip, which I think makes it very maneuverable and easy to get through very tortuous and calcified vessels, and then gives you the advantage of being able to pass a second wire through that as well. So again, thank you. Hope I did not go over my time limit, and I appreciate the invitation.
Well, this was a great talk, Babar. You know, you didn't touch on Caraval much, but especially for the epicardial curve, the non-torqueable, but that's also a very good catheter. You wanna, do you have any comments on the use of Caraval, where you would use it?
Yeah, so I gave that example in the case where I used it as well. It's actually pretty much, you know, I use it at least 50% of the time in my retrograde cases because I like the lower profile. It's easy to navigate through. I think as long as it's not too tortuous or not too much calcium on board, it's really just a very good catheter. And from our purposes, actually, it's one of the cheapest catheters that we have available to us. So when we have exchanges, even wire exchanges, where we get the benefit of using any microcatheter, we tend to use a Caraval as our first catheter.
So I actually have, I'll ask for comment from 2 different spectra. You know, we are talking about our North American and European perspective. I would love to hear from our Far East operators, you know, China, Japan, Hong Kong, etc., from the panelists. So what else do they have available? And after that, I would love to hear from Basir, Dr. Hanif, about our developing world challenges and, you know, reusing or sterilizing catheter. What are the challenges they face with the cost of it? So can I hear from any of our Hong Kong, China, Japan, any of those panelists?
Yeah. So what catheters you have at Tanzan?
We have only fan cross catheter, and also we have our Corsair catheter only, and also we have a Chinese-made catheter as well. Now we have our own Chinese-made microcatheter. It's called APCTO catheter. Yeah.
So there is some Chinese-made.
Yes. The Chinese microcatheter is similar to that of the fan cross. It's only kind of for and it's only kind of a delivery catheter. It's not for the screening. It's not for the screening. Yeah. So right now for the CTO, the most common catheter, most frequently catheter we use is a Coronary catheter. We don't have so many other catheters, microcatheters. Yeah.
Gotcha.
Yeah.
That's what's happening. Basir, Parag was talking about re-sterilizing these catheters. Yeah. Now that's really relevant in our part of the world, in India, Pakistan.
Yeah. As I mentioned, unfortunately, cost is a major limiting factor in these CTO PCIs. So we have Corsair and Fine Cross available, but again, unfortunately, cost is really prohibitive, and we do use sometimes actually re-sterilize these catheters. Although again, there is a lot of problem now because we have now healthcare commissions coming up, and they don't let us do it, and due to which again I think doing those CTO numbers are not that much in Pakistan just because of the cost issue. But we do keep some catheters, and when we have no other options, we do use those re-sterilized ones. But we make sure that we do obviously all the screening of those patients before using those catheters.
Yeah, my impression and my experience in doing CTO cases, I've not done them in Pakistan, but I've done quite a few of them in India, is that after maybe second or third time re-sterilization, especially Corsair, which is the only catheter that I've used in India as a re-sterilized catheter, it doesn't really work out so well.
I agree.
The wire gets stuck in the catheter. So I usually carry catheters from here to use them. But obviously, we don't have, it's really very late in Japan today, so I did not have any Japanese colleagues. But all the catheters that Mir is talking about, Japanese quite frequently use a ton of these catheters. But that sounds all great. In the interest of the time, we're going to continue to move forward. That's a great talk, Mir. A wonderful job. And now it's a privilege and honor to have Alaswad, who's a internationally renowned CTO operator, also from Henry Ford Health System in Detroit. And he's going to talk about tools to solve CTO complications. What really should you have in your hardware in your lab? And I think this is very, very important lecture. Kal, the floor is all yours now. Kal, your mic is on mute. Let me unmute you.
Okay, I'm unmuted now. Raj, thank you so much for inviting me to C3, and thank you for the course directors. This is a great meeting, and I love the intimate settings that when we are in Florida and here again, and even on Zoom, still feels the same. So thank you for pushing through with this C3 meeting, Raj. It's great. So today I'm going to talk about what you need as a emerging CTO operator in your lab. You have to have a solution. As you know, from multiple studies, we have increased complications in CTO. The safety of the procedure is getting much better, but we do run into situation like this. This is an RCA CTO. After we finished, I remember spinning the boss, and the boss went really rogue a little bit. So I solved it retrograde. I left the boss in there, and I went retrograde, and then after a stint deployment, this is what you find. So this is very important to know how to handle these kind of situations. And you have to have the tools available to you in the cath lab. Your cath lab staff need to know where these tools, so you don't go scrambling for it. And I would suggest, like Bill Lombardi always suggested, while you're doing a procedure in the middle of the case, stop and ask your staff to bring you the pericardiocentesis tray and to give you covered stent. And you need to make sure that these tools are going to be in your lab within 1 to 2 minutes. So otherwise you have to kind of sit back and train your staff again. So what to do when you have a large vessel rupture? We used to have the Jomid stent, and we were so happy to have the Graftmaster stent, because if you look here, the Jomid stent always needed 8 French guide and very difficult to deliver, and it was actually over the wire. So so if you have a short wires, you basically get stuck. So these tools, and I can mention multiple options and choices because this is a 5-continent talk, so I want to make sure everybody knows what to have. So some continent might not have everything, and in the US we tend to have something like a few of everything, but also the Graftmaster and some of the covered stent available in Europe, not available in the US. So you have to remember when you use covered stent, how can you deliver this? So if you have 2 guides, or if you have 1 guide, 8 French guide, you need to know how to deliver them if you have another wire in. So I tend to kind of bias towards 7 and 8 French guides for that reason, because if you have a perforation and you have a microcatheter or a balloon occlusion, can you deliver another tool? Can you deliver another covered stent? So remember 2.8 to 4, and remember the length. You need to know it's better to use the shortest shortest covered stent, but you have to make sure that you are sealing the entry and the outlet of the rupture area outside the stents, because if you've performed an ADR, what tend to happen that the adventitia stretches so big, so if you put a covered stent, the flow into that perforation might continue. This is the new stents in our market here in the US. It's a really excellent, it's not a PTFE, it's polyurethane fiber, and it's covered stent on 1 metal frame as opposed to 2 metal frames. So from that, you know, it's a much easier to deliver. And this is kind of the difference between the Graftmaster and the PK Papyrus stent. So this is the chart you need to remember. The good thing about those stents, you can deliver them actually in 5 French and 6 French guides. You do not need 7 French for those. So previously we used to have, if you have a perforation during CTO, we used to have a ping pong technique where you basically have to get another guide so you'll be able to deliver in those stents. Now you can deliver it through the same guide with a balloon if you have 7 or 8 French guide catheter. And here is a warning, easy deliverability comes at the price of easy strippability, like stripping. I was trying to make a new word in the English language, strippability, okay, strippability. So if you are trying to deliver it, you need to make sure that the stent does not strip off the metal frame, and you can't see it once you strip off the metal frame. So always examine, and when you go in, be careful and watch every step under fluoro, and if you have resistance, go back and dilate. These are the options. This is from my lab. They are in a prominent shelf in our inventory area where everybody knows where to find them. These are the Graftmaster. I actually kept both of them in the shelf because I don't want to be caught with one size not available. And I thought I will keep the Graftmaster until I make sure the PK Papyrus works really perfect before I take them off the shelf. But I'm going to keep them both because there is a question about type 2 leak. So if I have type 2 leak, I'll tend to use a different material. There are a situation you have to kind of know how to use a Viabond stent. This Viabond, a lot of peripheralists know how to use them. The situation where you need to use this is when the PK papyrus or the graft master don't work. When you have 6 millimeter vessel, and if you performed an ADR and you have a long rent in the vessel, you probably have to deliver this stent, and you have to go back to 6, and there is 7 millimeter and 8 millimeter basically. And those deliver over 0.18, but you can actually try to advance them over 0.14. But I want you to look at this number here. This is a 6 French sheath. So you cannot deliver those in a 6 French guide. This with 6 French here in the top, it's 6 French sheath, which is actually 8 French guide. So the 6 French sheath give you the space that 8 French guide gives you. And so you have to have a big guide in from the get-go. This is 7 French. So you might want to be creative in how to deliver those. And I wish we can have access to the Zuma guide catheters that 9 French. So this is from vessel rupture, the management of end hole perforation or a small vessel rupture. These are the things you need to keep in your cath lab. Thrombin topical, it's used, we use it previously for pseudoaneurysm closure. This is the FAT. There is a good video by Manos Prilakis. Please, guys, search it on YouTube. Fat embolization by Manos Prilakis, and watch it because this becomes handy. And these are the coils. You have to have coils in your cath lab. This is an RCA CTO where we actually severed 2 marginal branches. The patient developed ST elevation in V1 and V2. It was a clear picture of RV infarction. So what I did, I went back and wired this and kind of got a little bit of flow and wired the second branch, and trying to kind of dilate the second branch blindly. We dilated again here. I used 2 millimeter balloon, and if you look here, this is an hematoma over the RV. This is a very dangerous situation. If you have a hematoma over the RV get compressed. And this is post-cabbage, so you can't really tap this. There is no way to tap it. It's not free flowing. It's just building up, compressing your RV. So it's very important to react immediately. And this is how we treated this. We kept the wire in there. We started by kind of balloon tamponade for a long time. Then we looked, and there is a bleeding. So I wired it, and through a microcatheter, I delivered the coils. So this here, a very important point, you have to keep coils that deliver through any microcatheter you have. So there are coils, they need their special microcatheter. There are, most of the coils available in the cath labs are 018 or 035. But you need to talk to your neuroradiology colleagues and figure out what they do. You need to know how to deploy the coils before you start doing any CTO procedure. It's very, very important if you're doing high-end techniques to know how to deliver a coil. So if you don't know, you can call the reps, and they will come and show you and deploy a couple of them on the table. So the coils available, you have what we have in our cath lab. The advantage of the Axiom Prime coils is that they deliver through any microcatheter. You do not have to have special microcatheter. And this is a very, very important advantage, because the last thing you want to do trying to change a microcatheter. This is also the other advantage. It's not pushable. It's actually, you release it. And if I want to go back, do you see this handle here? It's very, very important, so that your cath lab staff, you tell them, go give me the coil. They get you the coil and they forget the handle. They don't think of the handle. So you have to tell them, give me the coil and the handle. However, you can break the back of the wire and deliver it. And these are the sizes I keep. You have to keep enough sizes, 4 millimeter, and this is 6 centimeter. So this is the sizes how the coil comes. And this is the diameter of the coil. So you have to keep big enough coils. So the 6 centimeter is the length if you stretch it. But this is if you leave the coil, it's just coils, and it's not going to cover 6 millimeter long. You have to have the 2 centimeters. So if you coil in closer to your parent vessel, this coil should not extend into your vessel. So if you rupture collaterals, you need to kind of deploy the coil far from the major vessel and major branches. And these are the sizes we have. Now, how about snares? Once in a while, you need snares. If you have coils, you should have snares in your cath lab. And I'm going to show you a case example why snares are good. And you have to know how to use them. Of course, we use the big snare to snare the wire, the retrograde, but you also have to have the smaller snares. And this is the Amplatzer. This is a Micro Elite snares. This is a case where we basically, this is an SVG going in a diagonal. We figure out we're not going to deal with the SVG. We're going to open the CTO. We really did not good outflow, and there was a lot of competition from the SVG. The SVG distal anastomosis, we thought it's really diseased. So I did not want to kind of rewire the SVG, so I delivered the coils retrograde, and this is the coils we want to coil the SVG so it will quit competing with our kind of really not very good outcome, but we thought if the competition from the SVG is going to close us again, and we're going to have to deal with it as a CTO again. There was multiple lesion, we treated them all, and we trying to obtain every branch. So I want you to see this picture here. So I'm trying to inject, and look what happened. So I delivered the coils retrograde in the SVG, and this SVG was like a Christmas tree. Start one, and there are 3 branches of it. So when you inject very forcefully, this is a small size. This is, although it's 4 by 6, this is still kind of flew backward when we injected. And I want you to see this, how the coil, look in the right panel here, how the coil basically went in the other SVG, one in the circ and one in the LAD. This is, we engage the SVG, this is to the circ and this is to the LAD, and these are the coils in here. So if you use coils in your lab, you need to know how to get them out. If you, fortunately, we were not able to push it back all the way to the aorta. It would have flown to the brain and would have been a disaster. So now how to get this out? This is, we tried the Micro Elite coil. The Micro Elite coils could not capture it. I had to use the Amplatzer micro coil. That actually has to be delivered through 018. This is a quick cross 018. We captured the first coil, and we had to wire and capture the second coil. When you pull something from trash from the coronary artery, you need to watch it coming down all the way out of the, away from the great arch vessels, because you don't want it to go to the brain. And this is here, we're trying to capture it, we couldn't. And so we finally captured it here, and we pulled it all the way out, and we watching it. You need to watch it really good going. And I like the big guides for also this reason, because the guides can take, if you end up having trash down the coronary artery, you can actually pull it back through these guides. So this is the final results. It's actually large diagonal, but still dissected distally. We accepted it, and we left that SVG alone. We did not want to coil it. You have to, your staff need to know this is not as emergent as a perforation, but this is very important number. You need a 018 microcatheter. This has to be long enough so you can actually go through your devices, 150 centimeter working. And this is the 4 millimeter coil micro snare kit. That's the Amplatzer. This is a 2 millimeter. If you are in a small side branch, you need actually a coil that opens up so you can capture. If you put a big coil, it's not going to open enough to capture the trash. And these are the Micro Elite. They are actually, you can control them proximally. You need to kind of learn how to use those coils. So do it at a tabletop as opposed to doing it in the coronary artery. Don't wait until you have trash in the coronary arteries to learn how to use these micro. These are the coils I keep in my lab. And this is 2 millimeter, this is 7 millimeter, and this is 4 millimeter. So I keep those 3 sizes in my cath lab. So if you are an interventional cardiologist and doing CTO, you need to learn how to fix the complications. And you don't need to be the jack of all trades and master of none, but you need to know from A to Z how to fix these things. And practice makes perfect. So you need to practice these things before you have to do them in a patient crashing and burning. Thank you so much. These are some of the books available if you guys, and this is my contact. I should remove this. Actually, CTO Fundamentals is not available anymore, but this is my contacts if you have any questions about my presentation. Thank you so much. Hopefully I did not go over time.
Thanks, Cal. It was outstanding. I'm going to order those Axiom 2x2 and 4x6 coils. They seem really nice detachable coils. I use some vascular trauma coils sometimes, but I think that this appears to be a nice coils from VV3. So we will use those. I think that, many of these concepts we are going to cover in the next few cases. So I think that, I want to make this a very interactive and it's a tremendous opportunity to have 3 master CTO operators going to show us 3 very, very complex cases and will give us an opportunity to discuss, some of this equipment that's been discussed as well as some of the complication tools. So I'd like to invite now Dr. Goran Olivecrona, who is a course co-director of C3. He's a professor of medicine at the University of Lund in Sweden, also a prolific CTO teacher. Many physicians in Eastern Europe have learned from Goran, including myself. Goran's been to my hospital many times to do towers with me many years ago, and we look forward to having him again. So Goran's going to show us the first case today. Goran, I'll let you take it up over now.
Thank you, Raj. And I don't know if I would call myself a master in this company with a great number of really outstanding operators here. But I'll show you a case that I thought was a little bit difficult. So I'll see if I can share my screen. One second. Do you see anything now?
Yep, we see your screen. It's coming up.
So this is a case that I did recently, or the last part of it. So I'll go through it, and it's maybe of interest because it involves a number of different types of procedural types. So these are my disclosures, and this is a 67-year-old male. He had CABG in 1990, so he wasn't that old then. He got a Lima to LAD, a vein graft to the RCA, which is kind of unusual because usually they have it to the PDA, but sometimes they write wrong in the report and so on. Anyway, the RCA was occluded at the time of the CABG, and he did well until 2017. He started getting some angina, ended up doing a SPECT. He had ischemia, 20% inferiorly of his left ventricle, and he sort of progressed in his angina to CCS class 3 and underwent an angiography in January 2019, which showed that the vein graft to the right coronary artery was occluded. Native was, of course, occluded as before. But I'll just show you some of these pictures and see if why this doesn't play. So this is very slow to play. This is the occluded vein graft. And the, let me go back. I don't know why it works so nicely on my computer, but
it's internet bandwidth in Europe, Goran.
I have a very high speed. So it should work.
There we go.
This is the left coronary, basically, and let's see if we can see the right. This is you can see collaterals, some collaterals from the native LAD to septals. And if you look upon the right coronary, you can see that this is a very ambiguous type of proximal cap. And what happens is then that, as I showed you, the vein graft is of course occluded, which you saw, and then we jump to the lima, which is actually quite open and is sort of the major supplier of the distal right. So the main supply to the right goes through the lima. Okay, so he comes back then, we want to plan this procedure, and if we can jump. So basically we did an RCA attempt, ambiguous proximal cap. We decided we need 3 access sites. So we have radial, femoral access, left radial for lima to the LAD, because that's how we visualize the right. And then we're going to be working, possibly through the left native system, and then of course the right. Well, the first plan was to retrograde wiring and included vein graft to the right coronary, then wire escalation, reverse cart. Plan B would be wiring the septal collaterals from the native LAD to the PDA, and then wire escalation possibly with a reverse cart. And as the last option, it would be antegrade attempt for sort of cross-bus stingray type of antegrade dissection reentry. So patient comes to the lab, and he's got actually quite good collaterals from the septals. As you can see here, this is a dual injection from the lima to the LAD, as well as to the left coronary. And if this plays well, you can see that there's, it's a very, very large branch, or vessel, this right coronary artery. So this is what we see here. And we then progress to start with the, this is just an overview of what it looks like. Sorry for it being so slow. I'm going to see if I can connect to our, you can see that it's a nice filling of a large right coronary artery here. And then we went to the vein graft, to the occluded vein graft, and we wanted to see if we can have that open. So basically wiring of the vein graft to the right coronary artery, which is often sort of a easy way to get into the distal vessel, using the vein graft as a conduit. And this is what we did. We continue then, this just shows that very often a pilot 200 supported by a microcatheter can usually quite easily go through the vein graft and down to the distal part of the vein graft, which we did. And the problem then that we discovered quite quickly was that it was a very unfavorable angle as we're getting down the vein graft as we approached the right coronary artery. And because of this unfavorable angle, as you can see here, we have to turn around basically 180 degrees and turn back up. And now it seems that this is probably does access the distal right coronary artery and not the PDA. So then we decided to switch strategies, and we wanted to access this retrogradely through the septal. So we wired the first big septal from the LAD to get retrograde from the right. So that's what we did. And this just shows that we're going down this route, and we access successfully the septal and to the PDA. We're over on the other side. And what happens is that the wire goes straight up into the vein graft. So we're sort of fiddling along, trying to get, the easy way would have been just to go up here and cross the distal cap of the native right coronary artery, get past the anastomosis, but the wire just keeps going up in the vein graft. Okay. so this becomes a little bit of a problem that there's an ambiguous distal cap. Where does the vein graft attach itself with anastomosis to the right coronary artery? So there's an ambiguity there. And we continue and try to see what it looks like, evaluate the distal cap. We can't see really where the cap is and where the anastomosis is. And it becomes then an issue of how do we bypass this? Well, there's a couple of ways of doing that. We start using a number of wires. We escalate up to 12-gram confianzas. We still only end up in the vein graft. Can't get past the anastomosis into the native. So then we have to sort of switch strategies again. And the next things that we do is to use Antegrade, but it's an ambiguous cap, so we use IVUS to resolve this proximal cap ambiguity, which I think was mentioned earlier and is quite helpful. It was still very, very difficult to understand where you wanted to have the wire go. But eventually we ended up in one wire position, which was kind of interesting. I don't know, it's moving so slow, but I don't know, but this wire is sort of really twitching back and forth and obviously not in right lumen. Eventually we could actually move some gear forward and change the position or the entry point. And we got another entry point and could get a microcatheter down. And once we think it looks like it's favorable, then we continue with a knuckle wire. So we went down here with a knuckle wire, and I don't know if we have to wait for it, but the knuckle wire comes down. It doesn't look quite so favorable anymore. It turns out to big knuckle. It doesn't really go where I think it should go. And when we check where we are, we can see that we have a perforation in this part. So you can see the small perforation. So that sort of stops our antegrade attempt, and we go back to the retrograde side, but have to do another kind of strategy. And then it would be to bring down the balloon in the vein graft and do an inflation in distal right and do what's called a base, which is a balloon-assisted subintimal entry. So while we have the balloon inflated in distal right, but through the vein graft, at the same time, we're trying to create a dissection, which we could then bypass up into the native right. But unfortunately, this is not successful either. So then we go back to using multiple, we try base with different types of wires, Filler XTs and Pilot 200s and Gladius wires and so on. Doesn't work. And so what do you do then? Well, the new strategy would be used to IVUS. So we went down with IVUS and see if we could see the anastomosis and figure out where we want to go with the wire. We went up with multiple wires to APCTOs and so on. But we still failed. So impossible to pass this on. This, I think, is with an APCTO wire we're trying here to go up. But it's unclear where we want to go. And the question is how far to push the envelope. So then there's this ambiguity, and we decided to stop the procedure. But one thing that was important was to bring back the patient, but do some added evaluations and discuss why did we fail. Possibly we didn't push the envelope enough using the base technique, but we were unclear about where the anastomosis was. So we decided to do a CT angiography and bring the patient back. And this is a CT angiography at right coronary artery. And you can see here that we pretty much figured out that about 10 millimeters away from the crux is where the actual anastomosis should be. And using this information, this is just how you can see the vein graft here. This is proximal. This is the RCA. Here they're getting closer to the anastomosis. And then eventually you end up here where you are in the distal right. And I'll skip to the next. So we decided to bring the patient back, same game plan, 3 access points, and we're going to really do a good retrograde base or side base, but this time much closer to the crux. And using the same setup with accessing the vein graft, going down that for the balloon, and going up retrogradely from the septal collateral to the RPD. So this is what we end up doing, and this is of course the base technique where you do basically an inflation. You crack the vessel and use the cracks to enter subintimally with your wire, and you can add a balloon on top of the microcatheter to sort of create your power base. It's the same thing, and the patient is now back. We can see that the injection shows that it's pretty much looks the same as before, so I'll jump to the next slide. Right coronary artery looks pretty much the same, still very much of an ambiguous cap, but it's healed well. And then we start accessing the vein graft. The problem is that the vein graft is not so easy this time. And we have much more difficulty going down the vein graft this time. Much more of a challenging entry. But eventually we get the wire down the vein graft, but we have to stop, not being able to get all the way to the right coronary artery. So now we bring in the wire from the septal, going down from the LAD native, and we cross over once again. So we're pretty much similar to last time, except we have to fix the access point from the vein graft to the right coronary artery. This is, like I said, more problematic, much more challenged to the wire, so we can't really bring the wire down further. So we end up having to essentially CTO procedure just to get our conduit down through the vein graft. This is, of course, a nice way to start a procedure, but we end up actually doing a reverse cart, getting the reverse cart. So this is from the vein graft, just to be able to pass down the wire from the vein graft. But we do that successfully, and now we're sort of have our setup here where we have a wire from the posterolateral branch, or from the vein graft coming down to the posterolateral branch. We have a balloon on there. We also have the, of course, retrograde Corsair catheter coming up. And now we want to do our base in this area here, inflate the balloon, and at the same time, trap the microcatheter with the balloon, and then force the wire to dissect itself past anastomosis. And this is then what it looks like when you're doing your base. So microcatheter is trapped. We're trying to push a knuckle wire past up, which will hopefully jump into the lumen. And we try this in multiple attempts with multiple wires. We're still unsuccessful in doing this. It's very, very hard, this whole thing. So this is the base procedure where we try to push our micro or our wire up but it won't go. So this is essentially maybe what I would call side base. In other words, part of the balloon is in the distal vein graft, and part of it is in the actual distal right, and sort of blocks entry into the vein graft. That doesn't work. So goes up into the vein graft the whole time, and we have to try something else. So then we start using stiff wires and go to up to the APCTO. Lots of wires are being used, multiple wires the whole way through. I think we used a total of 39 wires in the procedure. And finally, we can get a wire going somewhere up here. And I think this is an APCTO 40-gram wire that we use. And eventually, the 40-gram APCTO finds something. And we think it sort of accesses where the calcium is. We can bring the wire up a little bit further, and we're actually now what we think are in the distal or the right coronary artery proximal of the anastomosis. We can follow with a gladius wire and the gladius wire moving up a little bit further, but it's very, very difficult to get your Corsair catheter up with the wire. A lot of resistance. So this is good for, we actually used, I think, an 8 French catheter here from the left. But eventually we can get the microcatheter up past the anastomosis. And now we can then go using our Fielder XT wire to knuckle. But the Fielder XT wire goes up to a certain point and then it gets stuck. So you can see it's moving slowly. Apologize for that. But this is the Fielder XT wire knuckling up in this area here. And it gets sort of stuck in this area. So then you have to do something. And then we decided to try a knuckling of pilots and gladiuses and get a little bit further up perhaps, but we're still pretty much stuck. So then we do a mini Carlino, which is that we do an injection of contrast through the microcatheter in order to get a hydraulic dissection going up here. And might have been, sometimes it's helpful, might have been helpful here, but no incredible success anyway. So after that, it's back to using multiple different types of wires, again, to try to bypass and get access to the vessel architecture further up. Eventually, we can get a confianza going, brings it up in what we think is still the architecture of the vessel. And this is working then in 2 views simultaneously to see that here it looks like it's actually going in the correct direction and allows us to go further up. The whole thing is now to try to resolve the proximal cap ambiguity. And this means that continue to wire as far up as we can until we reach the proximal part of the right coronary vessel. At that point, try to resolve the ambiguity. And this is what we do. It takes a long time. We use the balloon here as sort of the anchor for the microcatheter, and then allows us to get a lot of pushability for the wire. And then after this, we can progress up with the wire. And now we're actually getting pretty close to the proximal cap. We end up moving the microcatheter all the way up here. And then we can switch back again to a knuckling using a Gladius MG, which is the Mungo wire. Once we get here, we use sort of what we call the power knuckle. The microcatheter is trapped with the balloon and pushing up here the knuckle wire. And you can see the loop almost going all the way up here. So it's not to the tip of the wire, but we sort of bend the wire several loops and then end up with the one loop that comes all the way up to this part. And you can see here the loop goes almost all the way up. So we move forward, and this is, you gain 1 millimeter at a time essentially. And now we can pretty much try to access the right coronary artery antegradely. And now we're very, very close to the actual right coronary artery. And this is the point where we think, okay, now we can resolve the proximal cap ambiguity, which we do at this point. And then we use very stiff wires. I think it was a 12-gram confianza to bring the wire into the proximal right coronary artery, so we can get parallel wires here, dancing wires, which will allow us then to do our reverse cart. After a long procedure, I didn't actually end up filming the reverse cart, but at this point, it took a while, but we finally were able to do a successful reverse cart. And now we've, at the next image as it comes. move. Okay, so now we've actually gotten the wire over in the retrograde side, or the antegrade catheter, and now it's a matter of externalizing the wire. And after that, the procedure went pretty much eventful, putting stents in and ending up with a result that looks, just 1 second. So here is sort of the final result of the procedure. Takes a little while for it to play, but you'll see that this is then the very, very large right coronary artery. And we can also, in the next image, you can see a little bit where the actual vein graft attaches itself, or did attach itself to the next image here. It was very, very close to the right corner, or to the crux. This is the old vein graft right here that's filling. So this is then the result, and the procedure follow-up time was 212 minutes fluoro time, 7.5 hours procedure times, 39 wires used during the procedure, no radiation injuries. I checked him after 2 weeks and he looks okay. He actually is doing quite well. He's symptom-free now at follow-up, but we plan to bring him back for an angiography. He's got some distal stenosis in the PL branch and the PDA, and I thought we'd sort of finish that stuff, but not at the time of the procedure. So I think conclusion: following a failed CTO PCI, you need to analyze what went wrong, perform additional investigations when possible, and in this case, the CT angiography I thought was very essential to resolve the ambiguities here. And discuss with colleagues the new game plan, buddy up with another senior experienced operator. 4 eyes are better than 2. You have a discussion partner at your table, reduces your fatigue and enhances endurance of the team. And with that, I'd just like to thank you for your attention.
Goran, thank you very much for the very complex case. It clearly was a test of the perseverance of a CTO operator. And I bet that, you know, as impatient as I probably would have quit a long time ago. But great job. So I think that we are a little bit behind. So I'd like to invite Dr. Jjyan Chen from China to show us the next case. Dr. Yan.
Yeah.
We were seeing it just fine.
Oh yeah. Now you can hear me, right?
Yes, we can hear you great.
Okay, thank you. Good day and good evening, everybody. I'm Dr. Yang Junqing from Guangdong Provincial People's Hospital, China, and I work with Dr. Chen Jjyan. He's my tutor, and on behalf of him, I'm so great to be here in C3 present the case. I think we're kind of behind the schedule, so I'll quickly show this case. It is a high risk and complex one. I'm not going to too much detail of the technical things, but I'll just adjust the JG. And basically, this is a young man, just 42-year-old, and he suffered worsened sort of near, sort of breath. And the bad thing is his heart is enlarged with the EF quite low, as low as 27%, and mild mitral figure. Here's the EKG. And he underwent some angiography in outside hospital. With the picture, we can see the LED occlusion, circumflex occlusion, yeah, and the right coronary artery occlusion. So now the question is how to treat this patient. Yeah, at the very first, the patient was transferred to the surgeon in our hospital, but you know what? The surgeon turned down the patient and referred him to us, to physicians. Actually, every year I treat quite a few cases like this. So we have some option. If we can, and if it is reasonable, we can recanalize the coronary artery with the PCI. If we cannot, if it is not good or we failed, the patient may have to go to the surgeon again and get some heart transplantation. This is the regular thing we did. And fortunately, when we check the PET, means photon emission tomography, we can see there's quite a mass of myocardial ischemia, but the scar is just 4%. Oh, it's good thing for the patient. That means if we recanalize the coronary artery, we can save some still viable myocardium. Yeah. With the angiogram at the very first, for me, I already have some image. I think to recanalize the right coronary should be the first choice. Compared with the LED, we can see the LED is also classified, but quite wrong occluded, and the distal vessel is not clear. And it's quite small. So if I have to do PCI for a patient, maybe the right coronary should be the first choice. And according to the PET, we can see the ischemia area was confused by all right coronary, circumflex, and the LED. So to pick up the right should be the first choice. Also, with the CT scan, we can see the right coronary over here. There is some calcium, like a circle around the vessel. All of us know that the classification is one of the difficulty for integrating open up the CTO in terms of the JCTO score. But for me, sometimes the calcium, if it's just like this, like a circle over here, it's a good thing for me. It can help me to find out the cause of the vessel and prevent the white going out of the vessel. But history, there is some nodule calcium over here, like a half circle. And history, also the calcium is distributed on the vessel wall. Anyway, to summarize for this patient situation, he's young with heart failure in large ventricle, with not so bad mitral situation, and then 3 vessel occlusion. But good thing is quite account of myocardium is still viable. So we have reason to request reservation for him. Cost turned down by the surgeon, the physician, the interventionalist should take the role, use PCI to open up. But I don't, I'll never to try to open up every CTO, 3 or 2 CTO in one procedure. So I plan to open up the right first and get the IVP and ECMO thereby. When we start the procedure, like 1 week before today, you can see more clear if you can share the video. Yeah, there is a quite long calcified CTO of the AAD, and the distal vessel is small. It's kind of negative remodeling, fused by some so-called diagonal or something, and there is a quite predominant septal branch fused here. Seems to take off of the very proximal LED or the diagonal, not very sure. And another thing we should notice that is the right coronary, the distal right coronary. I mean after the bifurcation, the tissue bifurcation of the right coronary artery, the PDA, PL still quite predominant. That means to open up the right coronary makes sense. Okay, another view, see circumflex also calcified and corroded, but some branches fills the free wall of the ventricle, the back ventricle. And okay, there is some lateral channel from the septal branch to the right coronary, and some other thing from the third. But I'll do my best to avoid the retrograde approach. You know what? Yeah, everybody know this patient is in the situation of COV ischemia. Any compromise of the left ventricle, left side coronary, I mean the donor artery, may worsen the ischemia and may cause some disaster. So primary, I try my best to do the antegrade approach, and we can see there's some region vessel from proximal to fuse the distal and show the distal vessel, the exit point of the right coronary occlusion. So to operate it, one of the important things is to prevent to injury the so-called region vessel. Everything region vessel. Something from here. Okay. And if we frame by frame carefully review the angle, you can see here at the bend there is very tiny like a tail over here, and this direct to the shadow of the housing. So there's some sign to show me that the entry point should be over here. Okay, this is the very careful analysis, and with the this view, I did the TV injection with the Corsair, also show some slides, what we mentioned, and with an AL1 Guidewire, and okay, microcatheter support. We select the guy first, then switch to kind of 200 Fox Pro curve, step by step. As I mentioned, always avoid to injury the side branch from side by side. I mean with different projection. Make sure the cost, the wire, the lens within the cost, within the shadow of the calcium. Finally, finally we get the Conx Brow 12 around the tip point punch several times and then switch to run through and get the wire, very carefully get the wire into the distal vessel and then advance with the 1.3 small broom, the broom rupture over here. It's quite tough. It's also touch fine. So we wrote it. This is the final, the final round. At the very first, there is something over here, and every time we just wrote a 5 to 10 stop. Try to avoid the blood pressure to go down too much. At the very first, when the patient get into the care stop, his blood pressure is only 90 over 50 something, at least. But anyway, very carefully with everything fine, and with the sand in two round sand, just 2 round sand, input in the right coronary, and this is the final result. Acceptable. And what sounds interesting, just after we put the stent over after right coronary, the blood pressure increase, it rise to 110, and the patient feels something better. Interesting. That's the best reward, and the patient discharged in 2 days. He's going to be follow up. With this case, I would like to say that for some critical patient, the procedure of the PCI will be complex and risky. Yeah, but maybe for this kind of patient, that if we can successfully recanalize the coronary artery, we can help the patient the best among others common patients. And in nowadays, our PCI takes its roles to help patients, including this kind of critical patient, the cardiac surgeon. Not always the final resolution, but everything must on the base of some expertise and carefully analysis and correct strategy and operation. That's my case. Thank you.
Thank you very much, Dr. Yang, for this wonderful case. Great job. Now I'd like to invite Dr. Doshi, one of our course co-directors and prolific CTO operator, to show his case.
Thank you.
Okay, Parag is actually must have stepped outside. How about
Raj, I'm here.
Okay, great.
Can you see my screen? Let me just see. Where is the, okay. I'm trying to figure out where.
If you hover your cursor.
Let Ashish show you how to do it, Parag.
I know. I thought it was easy. I have done this before, but
you move your cursor. It should be at the bottom when you move your cursor.
No, I clicked on it, but it gives me option of which windows, and that's what I'm trying to.
Yeah. So you pick the window which shows the PowerPoint in it.
And that's why I don't see it, and that's why I'm trying to figure out.
You have to go open the PowerPoint.
You open the PowerPoint first.
Okay, let me see if I can do it on. Does it show it or no?
Yeah, so why don't you play with it? You know, let me.
Why don't you go to next case and I can figure out that. How about that?
So I see Dr. Bin Lewis patiently waiting in China. I know it's late out there also. So if Dr. Lewis is ready, we'll have your case.
Oh, thank you, Dr. David. He invited me to attend the wonderful meeting. Yes, it's in China, it's midnight. Today, I will, can you hear me?
Yeah.
Yes.
Clear.
I will report two CTO chips case, PCI supported by ECMO. Case one, this is 78 males. He has angina for 10 years, and he has heart failure for 1 year. And before he came to our hospital, he had a dyspnea, and he has hypertension and diabetes, and he's a smoker, and he denied the history of myocardial infarction. The examination showed NT-proBNP is quite higher. V1 to V5 T-wave inversion. Ejection fraction is 30%. Chat CT shows pneumonia, pericardium, and pleural effusion. The picture shows left main has diffuse disease, and oscillum of circumflex has also stenosis, and LAD, the proximal LAD is occluded. The RCA is also occluded from the proximal part is occluded. This is a cerebral disease, and two vessel is CTO. He did not have myocardial infarction history. This time he has a very serious chest pain and heart failure, and also has pneumonia. According to the syntax score, we suggested to bypass, but the surgeon refused to perform catheter because they said he has pneumonia and has a very serious heart failure. They worried it will be not difficult to intolerance to do the surgery. So we decided to do PCI supported by ECMO. Further, we tried the RCA. From the picture, we can see maybe the RCA is not very so difficult. So we try to open the RCA further. We use the Gaia second to open, to pass over the occluded RCA and put stent. After balloon, we put stent in RCA. Then we switch to the left, and we try to open the LAD, but unfortunately, the wire cannot go to the distal of LAD. It go to the diagonal first. It's difficult to adjust the wire to LAD. So we use a small balloon to open the diagonal and use cruciate wire to use another wire to go to LAD, then put stent. During the procedure, the patient's blood pressure is very lower. During the procedure, it's lower than 90, and the patient has chest pain. But after the procedure, the patient's blood pressure went back to normal, and after the procedure, the chest pain was gone. If we do not use ECMO, we think it's difficult to tolerate during the procedure because the patient's situation is very bad, and blood pressure is lower. He had very serious chest pain and difficult to finish the procedure. After 1 month later, the ejection fraction increased to 46%. And 1 year later, ejection fraction is normal. The second case is a 67 years old male. He has very chest pain history for 10 years and aggravated for 2 months before came to here. And he also has diabetes and has a ischemic stroke for 12 years. Before he came to our hospital, he received to do PCI in another local hospital. And during the procedure, because the patient's blood pressure became very lower, so they did not finish the procedure. The NT-proBNP is very high, and the ejection fraction is lower, and he had pericardium effusion, and EKG shows all the inferior myocardial infarction. The picture shows the LAD has stenosis, and circumflex is CTO. RCA is CTO. Last time, in another hospital, they tried to do the RCA first. After the wire pass over, they tried to use balloon to pass the lesion. During the procedure, the patient's blood pressure became very lower, so they failed. This time, we also do syntax scan. Syntax scan also from syntax scan also suggest do surgery, but because the patients do not like to do surgery, and he has ischemic stroke 12 years ago, the surgery do not like to do it. So we decided to do PCI because in another hospital, during the procedure, he has unstable his blood pressure is lower, so we worried. In this time, he also have the same situation, so we choose ECMO support to do. With this time, we do the left footer. Footer we pass over the wire to circumflex, data of circumflex. The wire did not is easy to pass over, but after we opened the occluded lesion, the blood pressure, the blood flow became slowly, and the blood pressure and become lower. But because we have ECMO support, we do not worry it. And we after do the circumflex, we do stent in LAD. After that, we try to do the RCA. I just talked about, tell you, last time when they do RCA, the patient's blood pressure become very lower. And this time, after we pass over the wire, we use a very small balloon, cannot pass over, and the cochlear cannot pass over. So we try to do rotablator. After rotablator, we opened the artery and put stent. It shows slow flow. Blood pressure become very, very lower, and the heartbeat become very lower, and the systolic blood pressure is just 30. So because we have the ECMO support, the patients just complained he had very serious chest pain. We use a lot of vasodilator into RCA, and the blood flow recover slowly. Then we back to ward. Next days, the patients had sympathetic storms occurred on the second day after PCI. The patients had over 10 times of ventricular fibrillation because of refractory RNT PVB. And we do many times defibrillation, and 1 week later, we withdraw ECMO. The patients recover very well, and after 19 days treatment, the patient discharged. There was no obvious, no chest pain, and no dyspnea. Ejection fraction is 42, but anti-BNP was become lower. 1 year later, the ejection fraction increased to 62%. The patients looks fine. No angina, no dyspnea. Thank you. From these 2 patients, we think for some CTO case, if they have unstable hemodynamic ECMO support, might be very helpful to help us to finish the procedure. Thank you so much.
Thank you very much, Dr. Liu, for demonstrating excellent use of hemodynamic support devices to support CTO cases. You know, we have we could talk a lot about it because there's a lot of enthusiasm for use of Impella device in the United States, and also balloon pump device and ECMO in the rest of the world. So very, very nice presentation. Great save for those 2 patients. So now I'll have Parag is ready. He tells me that he can share his screen, and Dr. Doshi is going to now share his case. Parag, you are on mute.
Okay. Are you able to see the slide?
No, we don't see the slides.
So obviously I have some type of issue, then I think you may want to go, because I simply don't see my...
That's fine. That's fine. Let's have Bashir. Yeah, Bashir.
You know what? I got it. You should be able to see it now. Do you see it?
Yep.
Okay, finally. All right. So I have decided to show a case that's not necessarily the most complicated, but it's a rather interesting case. So this was a 24-year-old patient who had classic angina for 11 months, but they treated for anxiety. On November 3rd, 2017, she came with non-STEMI and cardiogenic shock at a small community hospital, seen by a cardiologist over there. She was found to have occluded left main, this 24-year-old girl, and RCA collaterals. She was treated with intra-aortic balloon pump and transferred to tertiary care. Over there, they worked her up for a few days, did some autoimmune antibodies, etc. Pershad rate was 92, CRP was 7.6, and actually, after 7 days, she underwent single vessel bypass with saphenous vein graft to obtuse marginal. She had an open aortic biopsy that did show non-specific vasculitis. For whatever reason, the lapse in care, she was discharged without any immunosuppressive therapy. She developed worsening angina again over the next few months, and on July 3rd, 2018, she developed unstable angina, went back to the tertiary care center in Chicago. She had an angiogram that showed critical SVD osteostenosis and left main CTO. She was not offered intervention, and she was started on steroids, and she had slight improvement in angina, and she was discharged home. And now she could not walk more than a block without getting severe angina. And she was referred to by one of my office staff because they were about to drive to Mayo Clinic, where also she was rejected. So to summarize, we had an osteal critical graft, and there was also left main CTO. I was in 2 groins, dual groin, 7 French and 8 French long sheath. Left coronary could not be cannulated at all. So I started with single 7 French GR4 guide in vein graft to obtuse marginal ostium. This is a still frame that again demonstrates there was a subtotal occlusion of the vein graft. Left main occlusion was identified. I had a sense, which I'll show you, that there might have been a microchannel in the left main. And as soon as I placed the catheter in the vein graft, she had a rather significant hemodynamic instability. This is the cine angiogram. For whatever reason, let me go to the next guy. I think the films are not working.
It's not seeing. It's not seeing where the file is, Parag.
It's on the local drive, so that's why it's surprising. I just played it 2 minutes ago. Huh.
Yeah, but you disconnected your dual monitor setup, and I think it may be on the other monitor.
Let me just see.
That's fine. Keep talking about the case.
So, basically, can you see the slide at all? Right.
Yeah, I see slide just fine.
Yes.
Okay, so let me see if I can now play it. Okay, so now it's playing. So you can see the graph is subtotal occlusion. There was an instant hemodynamic instability. So first place, I did the PTC of the vein graft to facilitate guide placement, 5 by 20 balloon. And since this was an early graft stenosis, I had a sense that I do need to give this young girl her left main back. This is actually the picture after the vein. Now you can see there is a backflow in the graft, even though it remains stenosed. And the left main may have some spill into the aorta. Again, I was not able to engage natively. So how did we cross the CTO? We took fine cross and CN wire from the graft. It was taken retrogradely, very easily crossed across into the aorta. I had CN exchange for RG3 wire over fine cross, which was now in aorta. We took 8 French EDU 3.5 advanced to thoracic aorta, and I used N-snare 18 by 30 millimeter. And remember, when we snare the wire in this externalized wire, we don't use the sheath or the catheter that comes with N-snare. The guide itself becomes the catheter for the snare. The wire was externalized outside, and we performed the left main PTCA with the externalized wire with 4.5 by 15 balloon. And this was the result after our initial PTCA. Once this happened, it essentially became an antegrade case. We crossed both LAD and circumflex with 2 separate wires. Retrograde equipment was all completely removed. Intravascular ultrasound was performed and using this as a guide, and did show totally fibrotic plaque as expected. There was no hematoma. The Resolute 5 by 12 stent was deployed, and it was post-dilated with Sterling 6 by 20 balloon. We took it to 24 atmosphere, but this 10–20% lesion remained. I did not feel right about trying to completely blow it out, since this was a fibrotic lesion in a young person who had localized vasculitis and inflammation. And I really was not comfortable trying to take it to higher pressure with a 28 or 30, so we left it there. She has done great. She was discharged on aspirin and Brilinta. Rheumatology started on methotrexate and high-dose prednisone. And at 2 years, she remains on very low-dose prednisone 2.5 daily and methotrexate. She's about to actually start law school. She had come back in 2 months with, I think it was 2 months. So to summarize, 24-year-old female with a vasculitis induced left main CTO, bypass failed, again, possibly due to aorto-ostial vasculitis. We stented the vasculitic CTO and with full and immunosuppressives with a great result. Short case, any questions?
Yeah, so Parag, what was the reason for suspecting vasculitis besides her age? Is she from another country?
No, so that's a surprising thing. She did not have any fever, arthralgia. She's a Hispanic female, but not in any other country. But the fact that she was 24, the fact that she had all vessels were completely clean, there was no evidence of familial or autonomous homozygous hypercholesterolemia. That was the only diagnosis. And I think at the tertiary care center, when they did the bypass appropriately, they took the biopsy, which did show non-specific vasculitis.
Right. No, I think it's a great case. One thing that I just want to let the audience know is that, whenever we come across patients, those who have potential Takayasu arteritis, our recommendation is that those patients be treated with immunosuppressive therapy first, to try to reduce inflammation before you embark on a vascular intervention, because sometimes these patients come in with a large vessel occlusions in the carotid, subclavian, peripheral arteries, etc., and they require intervention as well besides the coronary. So I think that the correct treatment was done. I agree with not necessarily having to be super aggressive and try to what looks like an under expansion of a very large stent. So that's fine. It looks great, Parag. We'll continue with the next case now. Dr. Basir Hanif is, I know even though it's very late in Pakistan, he's been patiently waiting. So he will now present the next case. I'd like to say a couple things about Basir. He's a course co-organizer for C3. He's also a ex-president of Pakistan Society of Intervention and has been a true champion of education in Pakistan, does many things beyond the call of duty to encourage young physicians from Pakistan. We have had opportunity to host many of his fellows and his colleagues, along with the society at C3. We continue to enjoy a strong relationship. Parag, in fact, has been to twice to Pakistan Society of Intervention meeting on behalf of C3 to represent C3 meeting. So great to have you, Basir. Thank you very much for taking the time.
Thank you very much, Raj. It's really always an honor and pleasure to be part of C3 on behalf of Pakistan Society of Interventional Cardiology and my colleagues in Pakistan. I would really like to thank you and C3 for giving us the opportunity to partner with C3 as always. And we are always delighted, not only myself, but my other colleagues in Pakistan. They always feel that C3 is our meeting. So can you see my screen?
Yep, we see just great.
Okay. Okay, so my case is not going to be as exotic as other cases has been. It's kind of a little bit simple case. But I can tell you the reason for presenting this is that just to show that we have our limitations, and a lot of times we cannot achieve what Goran was able to achieve, or a lot of my Chinese colleagues were. Our CTO volumes are not as much, again, because of the cost limitations, but we have a lot of our hospitals have started CTO programs, and gradually they are building up. And I think the events like this will definitely help to learn and get better at CTO PCIs. So my case is, this was a 69-year-old hypertensive diabetic gentleman who had a bypass surgery in 2009 using SVG to OM1 and OM2 and RPDA and Lima to LAD. He was admitted at our hospital with CCS3 angina with the dynamic STT changes on GDMT. His EF was 50% in view of CCS3 angina and on GDMT and ECH changes. His troponin I was kind of a borderline elevated also. We decided to proceed with the coronary angiography and graft study. So this was the graft study. His native, he had severe 3-vessel disease. His right coronary artery was severely calcified. LAD was occluded, and left circ also was kind of occluded over there. So in terms of grafts, his Lima was patent, although the distal LAD, distal to the Lima, had kind of a diffuse disease. SVG to OM1 was also occluded, and SVG to the right PDA also had a severe lesion in the mid part of the graft. The main culprit was this SVG to OM2. That was kind of a severely degenerated graft with multiple lesions all over. Two of the areas was super tight, more than 95%. The flow was kind of also slow. So we thought that instead of trying to fix this degenerated graft, maybe we should try to open up that native OM through the graft retrogradely. If you look at the native, I'll just quickly show you. Basically, antegradely, kind of the cap was ambiguous, so I was not sure. So I thought retrogradely I might be able to get to it. Just one second. Sorry. So what we did was I took two Summit French from the right radial and the right femoral, and we used XB35 in the left main and 0.75 AL in the OM graft. Now, because both the lesions were very tight, so I thought that if I use the microcatheter, the flow is going to be down and the patient might start having symptoms. So I decided to just gently dilate both lesions with a small 2O balloon, which I did the proximal and the distal part. And then after that, we took Horsehair Pro, which again I had that sterilized one. Patient has had cost limitations also. I started with kind of a Sion just to see how it feels, and then I moved on to Gaia2 and the Fielder XT. Initially, sorry, I'll play it. It was kind of not sure where the track of that OM is, because it seems it's going down and then coming up. all these 3 wires I tried initially going directly, but then since the track was not right, so I thought I'll go try to make a loop and get to the dissection plane and try to reconnect later. But despite trying all these wires with the loop, unfortunately the loop, I don't have the recording here, but the loop was really making really a big loop. And that was kind of a little bit worrying me, despite making small bends at the tip. And I also used Pilot 50 after that, Feeder XT. And each time the loop was so big in the OM, where I don't see the OM, that I was kind of afraid that I might be perforating. And because if you see the flow is also kind of down, and the patient started having chest pain with some EKG changes as well. So at that time, we had spent, like I would say, about half an hour to 45 minutes, and the patient was having pain and also ECG changes. So we decided actually to abandon at that time and just fix the graft now, just those 3 critical areas. And maybe I think with this degenerated graft, he's soon going to have worsening of the rest of the graft, and maybe bring him back and try to fix at that time. So what we did was that, this is again another view in which I try to get the wire antegradely and retrogradely also in the hair. The length seemed pretty long, and again the course was also kind of ambiguous of that OM native vessel. So we fixed the graft. I basically had because the size of the graft was very big and we didn't have 5/0 stents, so I took a BMS 5/0 by 20 in the proximal, and then 4/038 DES in the distal portion, and post dilated both with the 5/5 balloon. Luckily there was no evidence of any reflow. I gave a lot of vasodilators before putting the stents and before post dilating also. So the patient did okay. I don't know, I think I will like to have suggestions and comment from you to see what else could we have done to really get back and maybe have a smaller loop and be able to enter the native vessel retrogradely.
Yeah, so I think that we have caught up on the time a little bit now, so.
Yeah, sorry, just one last. I also fixed the right. That was simple, put it straightforward stent, and there was nothing. So thank you very much.
Parag, any suggestions?
Obviously, I think, the equipment availability also makes a difference. Basir is a great guy, but this is, I think, sometimes the size of the loop may not be as dangerous as you believe, because it's amazing how much you can stretch the adventitia. And then really, so as long as you loop so many times, I would continue pushing with the loop, even if the loop is wider to a point. But the vessel was so ambiguous and tortuous. I think having the graft as a retro and then from the front, so dual loop and then reverse card may or may not have been successful.
Dr. Khatri?
This is Ashish. So I think
Ashish, go ahead.
A good case. So I think one of the ways is when the loop gets that big, the reasons are a couple. Number one, you're exited the vessel, which of course is not desirable. But the other reason is that you're just being limited by the media. The way around that is I would have in some way come down the native left main like you were. I saw a picture of you doing that, but dilate and create an antegrade dissection in the proximal circumflex, and and then come antegrade. And once you come antegrade with a dissection, you have a better understanding about the course of the vessel, and you can resolve the ambiguity of the course distally, because then it'll answer your question as to whether you're exiting the vessel architecture or you were still within the OM/circumflex system. So I think a more aggressive antegrade knuckle with ballooning proximally would have helped, because no matter what you did, the ultimate strategy was going to end up being a retrograde dissection reentry strategy. So you have to anyway set up with some antegrade prep work. So I think if you had gone more aggressive, and I agree, when things get a little scary, when the knuckle gets really big, retrograde, and you want to basically do something different. And I think that one thing I would have done more aggressively differently is come integrate with a little bit more.
Yeah, I had thought about it, but patients started having chest pain and he changes. So I got really a little worried. So I thought I'll just go ahead and maybe when he comes back, then I'll try it that time.
Absolutely. I think that's a very valid, again, patient care comes first and CTO PCI is, again, elective. This is safety is more important. And you took care of his ACS and troponin elevation by taking care of both the OM graft and the right graft. So you have time. Ideally, there's a clinical study going on right now in the UK that's actually evaluating this exact same strategy. We debate all the time about when to bring people back, when they develop symptoms, or to electively bring them back in 6 to 8 weeks. And the next question will come about is once you open the native circumflex in the right coronary, what are you going to do with the graft? Should you coil the graft, or is there some strategy related to that? So both those are good questions, but ideally, I mean, I think bringing the patient back without symptoms in Pakistan might be a challenge from a financial perspective, but I think.
Yeah, and I would piggyback on what Ashish is saying in the sense it's the concept of the base of operations. So you were going retrograde, got stuck, got into a zone that made you uncomfortable from a safety perspective, is change the plan, change the script. And part of it is bypass the proximal cap, come down to antegrade. But, ideally we want to bring the retrograde system to the proximal cap, but many times that just simply doesn't happen. And then we have to choose an alternate course based on that, because you might be able to manage the safety aspects bypassing the proximal cap better than you can with a knuckle retrograde that's exploding until you can get the systems together. So just kind of rehashing what Hash said, so to speak.
So can I add one more thing, Craig, to it? So in this case, patient may have an ischemic because you had a degenerated graft subtotal already supplying that up to marginal, and when you put the microcatheter across that graft, you already develop severe ischemia. So some of these cases, I tend to actually proactively knuckle the wire down and shift the base of operation. So my actual dwell time within the graft is cut down.
Yeah. I mean, I think you when you're doing these, from my perspective, you minimize ischemic risk wherever you can, which means preparation, understanding your strategy, moving things upstream, because whether it's this case or others, the patients oftentimes can't tolerate it, or they can tolerate it only for a finite period of time. And as you start sliding off that curve, you get to an aspect where recovery can be really challenging, and that's the games we play. I mean, this has been a masterclass of cases that we've seen this morning. And to me, the educational component is a lot of things are possible. I mean, I think everybody that's on the webcast right now is seeing things that you almost can't imagine, that blow your mind. You give me heartburn while I'm drinking coffee watching them, frankly. But you see what can be accomplished. But also what you see is that CTO lends itself to creativity, but a lot of this isn't random. So the folks that are watching this, your mind is probably blown a little bit by what you're seeing, but what you're seeing is master operators that every time they've encountered a challenge and they've had 5 solutions and they work through every single one of them. So it's actually much more of a systematic process. So if you're getting engaged in a CTO program, this course is a really, really excellent starting package for understanding that this isn't random and people just throwing darts randomly. This is systematic troubleshooting, is what you've seen in the past 5 cases. And I think it's been a stellar morning, truly do.
Well, thank you very much, Craig and Ashish and Parag, for those great comments. Bashir, thanks for the great case. And now let's have Dr. Nadir Khan present his procedure.
are my slides up there?
We can see just fine. Yeah.
Great, great. So I'll be showing one of my initial cases that I did when I started PCI, started CTO PCI. And the reason I've chosen this case is that there are a lot of learning points especially for the beginners. So our case was a 50-year-old smoker who was hypertensive and had effort angina. His EKG showed T-wave inversions in the inferior leads with almost a normal ejection fraction with inferior wall hypokinesia. His MPS scan showed severe ischemia in the RCA and the LCX territory. PCI to the proximal RCA was performed in another center, and he came to us with persistent angina despite optimal medical treatment. So we planned a PCI to his circumflex CTO. So we started off with a Antegrade wire escalation approach. And this is a Fielder XT going subintimal. So the usual course of action would have been to go an Antegrade dissection re-entry, but unfortunately at that particular time, we are not familiar with the crossboss and the Stingray balloon, so we opted for the retrograde approach. But the retrograde approach was difficult in the sense that it was a very tortuous epicardial collateral connecting the distal right to the circumflex. And we were able to take the Corsair and do a selective tape injection in the epicardial collateral. So we got a Scion black wire crossed into the distal circumflex. And again, we visualized the position of the Corsair by contralateral injection. So we were able to put the Fielder XT wire retrogradely into the aorta, but you can see here is that there is no Corsair in the system. So the problem was that we couldn't the Corsair couldn't reach the left main. So we had to shorten the guide, and initially we thought that we would get away with it, but ultimately we had to shorten the guide, and this took some doing. So ultimately we were able to reach with the Corsair the tip of the left main, but unfortunately we were unable to externalize the wire. Although you can see that we have changed from a XB to a Jjyan left guide, but still we couldn't externalize the wire. And again, we tried with a Guidezilla, but I think the mistake here we are doing, which our Chinese counterpart just previously alluded to, that rather than moving the wire, you should move the guide cath to sort of align with the wire. So we were not able to externalize this wire. So after a lot of attempts, we decided to snare the RG3, and then RG3 was externalized from the left guide, and then the procedure was not very difficult. This is the procedure after ballooning. This is how the circumflex looks like. So this is after stenting and post-dilatation. So its circumflex has been reconstructed. But unfortunately, when we checked the donor vessel, there was a dissection and thrombosis in the donor vessel. So it's very important to check the donor vessel in the end, because sometimes these things can happen and cause a calamity. So we ballooned it, but the result was not very good. So we had to stent this proximal section, and the end result looked okay. And this is how it looked like, how the circumflex looked like. Thank you very much.
Thank you, Nadir. Any comments from panel members?
But this is a great case, Dr. Khan. I think you've done a good job. It's certainly not a beginner's case. And I have worked with Basir at Taba, and I think You guys are phenomenal operators in Pakistan, eagerly absorbing new techniques and doing a great job. So congratulations to all the Pakistani colleagues.
Thank you, Parag. And Nadir has been a great operator. He's the earlier first ones actually who had started the CTO program at his institute and has really done a lot of them. So he's one of the earliest ones. Thank you.
Thank you very much.
Goran, do you want to say a couple things about importance of, keeping an eye on the donor artery and how to best prevent the complication in the donor vessel?
Yeah, I mean, exactly. It's a very nice case and really good to present this because this is something to keep your eye on. You get so caught up in externalizing the wire and doing it working there that it's easy to forget that you have a donor vessel also, and this can be a complete disaster. And you solved this beautifully, but this is one of my neuroses that I have about, not pulling stuff out until I've sort of checked everything that the donor vessel is okay. So I think this is a beautiful example of exactly what can happen, and keep your eye even also on the donor vessel.
Just three thoughts. Number one, make sure that the ACT is more than 300 at all times during retrograde cases. Number two, what we've done is if there's any intermediate lesion in the donor vessel, take care of that, because I think roughing that up with a microcatheter or a guide extension often lends itself to the artery dissecting. And the third thing is you just put a wire down just for whatever reason right before you start, so that the donor vessel has antegrade wire access, and if there is a dissection, then putting a balloon in is not so challenging. So
I'd agree with that. I would just add on that if you're uncertain about your wire crossing in proximal vessels, let's say a left main or a proximal right coronary, you could put an IVUS in or some other imaging modality. Convince yourself that your retrograde wire is in the correct spot before you take it a bridge too far and create additional risk. I think in this case, we saw that the base of operations, the effective area where we can kind of do battle, was pulled away from the left main. And that it's a subtle but very important characteristic of these procedures is kind of try to create the connections in areas where you can increase your confidence and avoid trouble and safety issues. And I think this is an excellent example.
I agree completely with Craig. And
hemodynamic support in a single donor artery.
So your question was the importance of hemodynamic support, right?
When do you use it?
Yeah, so again, I'll give my own biased perspective. If you're going to use the hemodynamic support, I think the balloon pump is not sufficient. If you need the support, then I think I start with the impeller, because if you are okay with balloon pump, then usually don't require the support. What do you think, Craig? Is that
in China, we currently we don't have impeller support available now. It used to be in the market, but this year it has been out of the market because it didn't pass the FDA renewal of the approval. It used to be available. Currently, it's not available. So like Dr. Liu Bin's case, currently most of the hemodynamic support is from ECMO support. We use the ECMO support. So the impeller, you use impeller, most likely you remove the impeller catheter after the procedure, or you continue the impeller for several days for most cases of the CTO.
Yeah,
I think that depends on the case.
I mean, my sense is you support is probably almost compulsory for a very small percentage of patients. There's some where it probably makes it a better procedure, but if you don't have it available you can do, there's a gray zone where you can do a lot of this without support, truly. And I mean, I enjoy Impella and ECMO as much as the next person, but it's not necessary for a lot of these things. But if you're doing it without support, that's where you kind of have to understand your own personal experience and comfort level, because some things that under support, you could take your time and execute and be thoughtful. It becomes spinal reflex and you're moving very quickly. And in order to move quickly, you need an experience level. So I think it's a matter of kind of understanding yourself and managing that versus patient-specific risk.
To answer your question, Raj, I think in my estimation, a low EF patient with retrograde work, I think the risk is exponentially higher, and I have a much lower threshold to consider support in that circumstance. On the other hand, low EF patients with antegrade work, as long as, like as Greg suggested, you're efficient and have a level of experience and expertise and a good bailout plan, i.e. an understanding of what the contralateral groin looks like, et cetera, before you get going, or have planned access available rather, so that you're not caught with your pants down with 2 8-French sheets in the groin, and then you're wondering how the heck are you going to get access for a device that you need to get in, are important considerations to have upfront rather than do it in the midst of the case. Because having said that, and I love support as much as anybody else, they come with their own set of risks and complications that you have to put into perspective that clearly will make your PCI, and let alone CTO PCI, a vascular risk much higher.
Yeah, I agree with all of those fantastic comments. You know, I think it's important for folks in the Asia Pacific region to be cognizant of, you know, these facts, given that not all the devices are universally available in that zone. So keep in mind that they may only have a choice of either IABP or ECMO. And ECMO also not universally in all the situations. Anyway, let's continue. Let's now invite Dr. Asim Javed to present the last case of today.
Thank you very much. I'm very grateful for giving me this opportunity today. Let's share my slides. Can you see my slides?
Yes, we can see just fine.
Okay, great. So thank you very much again. And it was a wonderful webinar, great learning points all over, and excellent cases shown. So I can't show you anything more complex than what has been shown already. So I'm going to show you a rather simple CTO, but it has an interesting learning point in it. So my patient is a 55-year-old gentleman. He had angioplasty done about 4 years ago with a bare metal stent to the right coronary artery and a drug-eluting stent to the LAD. This time he presented with effort angina CCS class 3 despite of optimal medical therapy. So as you can see, there's a 100% ISR of the RCS stent, very osteal placement. And the mid-LED stent is patent, and you can also see the distal RCA being cross-filled from the left system. The difficulty that I had in this case was my initial plan was to go integrate here, but it was very difficult to engage any guide catheter and to make it sit coaxially in the right coronary artery. So I tried different shapes and everything, and nothing worked. So I tried wiring, staying slightly away, but it just wasn't possible to go with an antegrade approach here. So I decided to go retrograde, and the septal that I selected was this septal, which was relatively straighter, but it was coming out of the middle of the LED stent. It wasn't difficult to go through the stent and into the septal. I used a Corsair and a Seon wire and could manage to go retrogradely. Came up to the stent, and then in RCS stent, I used a Pilot 200 to go across, and then I didn't have an RG3 at that time. I used a rota floppy wire for externalization later on. And just to save some cost, did not opt to go with an Antegrade microcatheter and change the wire. So rather I brought in a 338mm drug-eluting stent on my rota floppy wire Antegradely and deployed the stent. So this is the result after doing everything else. But the problem here again was I still could not manage to engage my Antegrade guide catheter coaxially. It was still giving me a very hard time. So I decided to bring in an REVASC catheter to see what exactly was happening here. So this is a still image to show you what exactly was seen on the REVASC. So what I think happened here is, this is exactly what happened. I came retrogradely, the old RCS stent is deployed here, and I think it probably wasn't hanging that much into the aorta as much as I've drawn here, but I think my wire, instead of exiting through the middle of the stent, it probably exited through one of the side struts, which I could not realize at that time. So my whole ballooning and stent deployment, I think, was done through the side strut rather than through the middle of the stent. So what we see here on the IVUS is that the IVUS is clearly outside the stent. So initially you see the IVUS catheter outside the stent, and then as we push the IVUS catheter into the stent further down, you can see two lumens of the stent. One is the new lumen which has been created with the newly deployed stent, and the other one is the old collapsed stent in the initial maybe 2 or 3 struts that are now collapsed. So next thing after realizing this is we bring in another 4x12mm stent, make it slightly more ostial, and then give it a good blow up, flare the stent properly with a 4.5mm stent, and then after stenting, this is the IVUS run. You can see now it's much better deployed, and you can see that initial part of the stent, which was much bigger initially, the old collapsed stent, now it's relatively smaller here, and this is that part of the stent which is now hanging in the a millimeter or 2 into the aorta. So this part could not be collapsed any further because there's no RCA wall to collapse it against. And this is then the final result. And now the catheter could easily sit in. And so it was a simple CTO approach coming retrogradely, but it was an interesting learning point that this can also happen, that at the end of the procedure, the wire exited from the side struts rather than going through the middle of the stent. Thank you very much.
That's fantastic demonstration of use of imaging. We very strongly believe in it. You know, the entire effort for PCI optimization, you know, C3 has been very committed to it. In fact, we are working on a brand new hub program for PCI optimization. So really excellent demonstration. Any comments from panel members?
I mean, I think it's an excellent example of having to recreate what you want to accomplish. If you're through a side strut, I mean, we find in CTOs and other areas that you're in a strut and need to crush things aside. But if you do it like this, imaging intelligently, sizing it, really getting it optimized. And for me, the learning lesson from this case is, how do you end a procedure with an exquisite and perfect result, which technically speaking will end up with a great result for the patient? And this is just a wonderful showcase.
That's great and very well said, Dr. Thompson. It's exactly noon, which is where our webinar ends. I want to thank Dr. Yuji Zhao from China, Dr. Eugene Wu from Hong Kong, and Dr. Bashir Hanif from Pakistan to co-chair this session. We crossed 4,500 delegates today. So I want to thank everyone in Asia Pacific who stayed up very, very late. I know it's almost crossed midnight in China and Pakistan now. So A lot of people are online, so I want to end this in a timely fashion. I want to thank all the faculty members, Dr. Thompson, Dr. Khatri, Doshi, Ashish, who woke up very early in the morning today, and Goran, it's also very late in Sweden, to be a part of it, while Lou has worked very hard in China. I see Dr. Jjyan Chen is still available in China. Thank you very much, everyone, to be part of it. We are working on part 2 now, and I will have that announcement very soon for CTO. Thank you, everybody, and have a great rest of the evening and great rest of the day in US. Thanks so much.
Thank you, Raj.
Thank you.
Thanks, Raj.
Thank you.
Thank you, Raj.
Thank you.
I enjoy
Raj.
very much.
Everybody, have a good evening.